All right. Thank you, Clint. I'm going to call to order the November 18th meeting of the North Dakota State Health Council. I'd like to start the meeting off by making sure there's a quorum available. If Londa is available, looks like she stepped back out again. And for those of you who are not used to these types of calls, please remember, if you're not speaking, to mute your phone. And if you do have your microphone open, we've learned already that shuffling papers does carry across on the microphone. So please be a little bit diligent in that. If I have an issue, don't be afraid to point me out as well. I need to be accountable for just like everybody else. Let's see. I don't want to do a roll call without Londa present because she is the one who would record that. So. Okay, thank you very much. So State Health Council members who are present. Let's see.
Dwayne, this is Brenda. Yeah. Would you like me to take roll call for you?
Sure. I was going to flip over to my page that has everybody listed on it, but if you don't mind.
I don't mind at all. James Brousseau.
Present.
Jenny Dietzman.
Here.
Mike Fedorchuk. Is Mike with us today?
Mike actually is not participating anymore. He hasn't turned in a letter with the governor's office yet.
Oh, okay. Well, thank you, Dwayne.
So he's still officially a member, but he hasn't been.
And okay, and our chair, I'm so sorry, Dwayne Poole.
Here.
Vice Chair, Dr. Dennis Wolf.
Here.
Secretary Daryl Birch.
I'm here.
Wonderful. And then Kristen Rohr, Senator Rohr. Here. Thank you. And Tori Saylor.
I'm here.
All right, Mr. Chairman, you do have a quorum, and I think I'll stick to budget. I didn't do that real well.
Thank you, Brenda. All right, with a quorum present, let's move forward with the agenda. The first thing is the agenda itself. Are there any additions, deletions, or movements in the agenda that we'd like to see? Dr. Wolf, you need to take your phone off mute. Dr. Wolf, were you saying something?
I'm here.
Okay. Did you have any additions or deletions or movements to the agenda?
No.
There's one item that I'd like to add to the agenda with your consent, and that is to have Dr. Stephen McDonough provide us with a brief statement that he's prepared and asked to present to the Health Council. He has a history with the Health Department, is very active in the public health community, and is a practicing physician. I'd like to add him in at 9 o'clock if we can. Any objection?
I would move to approve the agenda with the addition as requested by Dwayne.
I second that. Unmute.
I don't think we need anything other than just a consent vote on that. So everybody who approves, say aye.
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 Opposed? Hearing no opposition, we'll add Dr. McDonough to the agenda at 9 o'clock. All right, let's go through the agenda as it's set up. I believe the first thing on the agenda are the minutes of August 12th and the special meeting for October 16th. We'll take them one at a time. Have we had an opportunity to review the minutes of August 12th? Has anybody not had the opportunity to review the minutes of August 12th, I should ask? Okay. Is there a motion to accept the minutes as presented for August 12th?
I so move to accept the minutes. This is Jenny Dietzman.
I'll second. Jim Brusso here.
Any discussion over those minutes? Hearing none.
Dwayne, do you want me to take the roll call vote for you? This is Brenda.
Sure.
Okay,
Thank you very much, Brenda.
you're very welcome. Chairman Poole,
Yes.
Vice Chair Dr. Wolf,
Yes.
Dale Birch,
Yes.
Rousseau. Thank you. Thank you. Jenny Dietzman.
Yes.
Okay, and I don't believe Mike has joined us. Oh, you told me that's the one that's going to be leaving.
There it is.
Did Tyler join us? I'm sorry. Okay. Senator Roars,
Yes.
and did Tori join us?
I'm here. Yes.
Yes, okay, thank you. Motion carried.
All right. Now the October 16th minutes. Has anybody not had an opportunity to review them? All right, everybody's had an opportunity to review them. Are there any changes, notations, modifications to the minutes that you would like to see? I know that Daryl had some questions over them earlier. Had those been addressed, Daryl?
Yeah, yes, they have.
Are there any other questions or comments on the minutes from the October 16th special meeting? Hearing none. A motion to approve?
I'll move. Jim Brusso here.
We have a motion.
Second.
Second.
Roars.
Second.
Was that Kristen that seconded?
You had a couple to pick from, but sure.
Yeah. Have a motion, a second. Just take the roll, please.
Oh, sure. And Londa's still trying to get connected. They're working diligently on that. Chairman Poole,
Yes.
Vice Chair Wolf,
Yes.
Secretary Birch,
Yes.
and Brousseau. Jenny Dietzman,
Yes.
Senator Roars,
Yes.
and Tori.
Yes.
Okay, motion carries.
Motion carries. The next item on the agenda in our winter meeting, we review the slate of officers and open that up for those individuals interested in serving in positions or those who are interested in nominating individuals to serve as officers. We need to vote on a chair, a vice chair, and a secretary.
I nominate Jim Brusso for the chairman.
Mr. Brousseau, you have a nomination?
Isn't it sort of the tradition, though, that the chair serves for 2 years and that the officers serve for 2 years?
Yes, it's a tradition, but given our interesting times, I'm open to whatever makes the most sense for the council. I'm not held to this position.
I appreciate the nomination, but I'd like to decline that in favor of having Dwayne stay on for another year.
Okay, I'll retract my original motion and will nominate Dwayne.
Okay.
We have a nomination. Do we have a second for that nomination?
I second that nomination.
Thank you, Jenny. So, in favor, roll call.
Okay. Chairman Poole,
I will abstain.
Okay. Vice Chair Wolf,
Yes.
okay. Secretary Birch,
Yes.
Dr. Brousseau. I think your mic might have been muted, but I think a yes.
Yes, I approve of the nomination.
Wonderful. Thank you. Jenny,
Yes.
Senator Roars,
Yes.
and Tori.
Yes.
Motion carries.
Okay, and now for vice chairman and secretary. Nominations for vice chair.
I will now nominate Dr. James Russo.
Dr.
What's
Brousseau,
what's this nomination for?
vice chair.
I nominate James Russo. Wolf.
I second that nomination. I think it would be good to good balance between the two of you.
Dr. Brousseau, are you willing to move forward with that nomination?
I'd be willing to accept that nomination.
May we have a roll call, please?
Chairman Poole,
Yes.
Vice Chair Wolf,
Yes.
Secretary Birch,
Yes.
Dr. Brousseau.
I think I abstain from this vote.
Okay. Jenny,
Yes.
let's see, Senator Roars,
Yes.
and Tori.
Yes.
Okay, motion carries.
All right. Nominations for the secretary. Daryl, are you willing to serve again?
His video looks frozen.
Yeah, he does. I think
Where did it go?
video equals acquiescence. So. Do we have a nomination for secretary then?
I nominate Daryl.
Is there a second?
If he's willing to accept the nomination, I would second that motion.
All right. We have a nomination and a second.
Oh, Daryl is back.
Daryl, do we accept thumbs up as a yes and thumbs down as a no if your audio is messed up? Okay.
Yeah, sorry, I got disconnected for some reason, but I'm back.
Wonderful.
Vote. Roll call.
Chair Poole,
Yes.
Vice Chair Wolf.
Yes.
All right, Secretary Birch, I assume you're going to abstain from the
Abstain.
vote? Okay. Dr. Brousseau. Yep, okay. I think I nod. Yeah, okay. And Jenny,
Yes.
Senator Roars,
Yes.
and Tori.
Yes.
All right, motion
Motion
carries.
carried. We have a slate of officers. Thank you, everybody. We'll move forward in the agenda. At this time is, rather than go into the budget, how long will the budget discussions take, Brenda?
It'll probably take more than 15 minutes. So instead of interrupting that flow, if I'm certainly willing to offer the floor to Dr. McDonough.
Okay, seeing that Dr. McDonough is on already. Dr. McDonough, would you like to provide your statement to the council? Can you try and keep it to about 10 minutes?
Yes, Mr. Chairman, it should be less than 10 minutes. Can you hear me?
Just fine.
Okay. Good morning, Mr. Chairman, members of the council. I appreciate this opportunity to speak to you today on the COVID outbreak in North Dakota. My comments will focus exclusively on where we are now and where we should go from here and will not follow the written testimony. North Dakota has experienced the greatest outbreak of COVID in the U.S. for the past 3 months with no end in sight. We have a case rate higher than any other country in the world and the highest 7-day average death rate in the U.S. for the past month. Yesterday, 26 Deaths were reported, giving us a total of 769, and nearly 1,000 more North Dakotans are expected to die in the next 3 months unless we can get mask usage up to 95%. The percent positivity of tests at Bismarck Sanford is nearly 40%, indicating an out-of-control epidemic. Sanford yesterday announced opening of 3 freestanding 20-bed COVID hospital. Emergency and intensive care physicians and nurses and ancillary staff are stressed and exhausted. Many have become ill or are in quarantine. There is a real possibility of an overwhelmed healthcare system. COVID has decimated rural healthcare. When the pandemic first arrived in the U.S., many thought that we would be safe because the rural state were naturally socially distanced. That showed a fundamental misunderstanding of North Dakota culture. Our citizens love their families, churches, and communities, and frequently congregate in school gyms, churches, restaurants, bars, and community meeting places for celebrations, weddings, and the ever-increasing number of funerals, all perfect settings for COVID to strike and spread. Just look at Dickey County, with 21, actually now 22 deaths and a death rate 241% higher than the state of New York. That's right. Since the beginning of the pandemic, a resident of Dickey County, population 4,970, was 2.5 times more likely to die than a resident of the state of New York, population 19.45 million. Several other counties have higher death rates than New York. The outbreak is widespread in North Dakota, with 38 counties having a higher active case rate than Cass County, our largest county in North Dakota. COVID is everywhere and deadly in rural North Dakota. Where do we go from here? I am here today to ask you to do 5 things. First, support North Dakota's governor's mask mandate issued a few days ago. I would recommend to the governor that penalties should be based on a citation model. $25 for the first citation, $100 for the second citation, and community service for the third citation. The threat of a criminal offense is not necessary. There are other ways to deter irresponsible behavior. Number 2, request that the North Dakota's governor and the North Dakota Department of Health to change the county risk categorization to one based on 7-day average of new cases per 100,000 and the percentage of mask wearing in each county. The current risk categorization has not served our state well and underestimates true risk. Having county mask wearing on the risk categorization will incentivize mask use. Once our county achieved 95% mask use, which is necessary to reduce deaths, their risk categorization would lower one category and businesses would have more customers. Number 3, direct the Department of Health to release the results of the October 2020 mask wearing survey and to conduct monthly surveys of mask wearing and social distancing and release those results to the public. Until recently, North Dakota had among the lowest rate of mask use in the United States. Mask use and social distancing are essential measures that need to be surveyed until the pandemic disappears. 4th, direct the North Dakota Department of Health to revise the current public education effort for wearing masks and the importance of social distancing. There are 6 reasons for wearing masks. The first is for life, 2nd, grandparents, 3rd, the vulnerable, 4th, healthcare providers, 5th, the economy, and 6th, your family. Leaders do not let their opponents define the issue. Leaders instead define the issue. There is no right to not wear a mask during a pandemic, as there is no right to smoke in a public place, drink alcohol irresponsibly, and drive 120 miles an hour on the interstate. These are all actions that threaten others. There are, however, at least 6 reasons for mask wearing, and I repeat, the first is for life. You support life by wearing a mask. Grandmas and grandpas, you love your grandparents by wearing a mask. The vulnerable, you protect the vulnerable by wearing a mask. Healthcare providers, you respect healthcare providers by wearing a mask. Economy, you help the community thrive by wearing a mask. And family, you save your most precious relationships by wearing a mask. Public education on these 6 reasons should be blanketing the airways print, and social media until it becomes socially unacceptable to not wear a mask in public or commercial indoor air. Education should also include basic information on how COVID is spread, how masks work, and how effective they are. Focus groups should include those opposed to mask mandates and mask wearing to tailor messaging. Fifth, support the governor's order to require counties and cities to enforce social distancing as indicated in the risk categorization. The COVID outbreak in North Dakota is the worst in the world, so I would have preferred the restaurants and bars operate at 25% capacity and that they be compensated for lost revenue by the state of North Dakota. Since the governor has established a 50% occupancy in the mandate, I suggest that it be dropped to 25% by December 1 unless county mask wearing achieves 95%. Until social distancing measures, other social distancing measures should be guided by epidemiology from the North Dakota Department of Health and the nearly 66,000 cases reported. The events and facilities responsible for the most cases should be prioritized, and recommendations for weddings, celebrations, and other gatherings should be made. The time for happy talk is over, and the time for tough love needs to start. Communities should be required to take responsibility for their actions. Once mask use gets to be 95%, it will be safer to go out in public and businesses can be more open. Unless we take this seriously, Thanksgiving will go on as before, Christmas office parties and seasonal events will become super spreader events, and the pandemic will go on unabated until January. Our healthcare providers, elderly and long-term care, and the vulnerable deserve much better. Mr. Chairman, members of the council, you have not been provided the opportunity to advise the North Dakota Department of Health on the COVID-19 epidemic. That time is now. You have seen where the current approach has taken us and where we must go into the future. I hope you will seize this opportunity to discuss and act on these 5 measures, in addition to others that will undoubtedly come up today. Thank you for your time.
And you are muted.
Yep.
Thank you, Dr. McDonough. Thank you for your service to the state in the past and your current service to the healthcare in your community and specifically your patients. And thank you to the other healthcare providers that are seeing the same stresses that you are in their work and their workload.
I have a question for Dr. McDonough. Can you hear me okay?
Yes, sir.
Okay. Yeah.
Well, Dr. McDonough, thanks for your testimony. and we've read your letters to the newspapers and interviews and so forth. I was wondering if you've had any direct contact with the governor's office with your recommendations.
No, sir, I have not.
Okay, thank you.
Listen, Jess, well, I think all of these recommendations are important and we need to act upon them and send a letter to the governor in this regard.
Okay, well, let's keep that in mind, and as we get further down the agenda, let's keep these in the front of our mind and make sure that if we have any actions from this meeting that we include a lot of those issues. And I know that several of us have had conversations in the past about needing more of a strategic approach to the pandemic as opposed to just a testing strategy. And I think some of these play into specifically what an actual strategy is to deal with the pandemic as opposed to what a strategy is for testing.
On a personal note, Dr. McDonough, you published a book on the history of the health department. Was that called An Ounce of Prevention?
Thank you, sir. In our centennial year in 1989, I published a 300-some page book with called The Golden Ounce, A Century of Public Health in North Dakota, and it went back to the territorial days, covered the Spanish flu epidemic, and yeah, it was took a couple of years to write, and it was a centennial, official centennial project, and It was about public health over the past 100 years, and I'd like to say that what I learned from that is we've had periods in time, we've had great public health leaders over the years. Dr. Grasick in the fight against tuberculosis, Dr. Maso Williams, one of the first female public health officers in the country during the Great Depression, and was fortunate to work with Dr. Wentz during my time in the health department. And what I learned from that, and this applies for the time we have before us today, you do the right thing, you fight the good fight, and you always look after the most vulnerable. And that's what I've been trying to do since July. And I really think that the Health Council has a very important role to place, or a very important role right now during this historic pandemic. When I was writing the history of public health, I went back and looked 100 years ago in the newspapers in North Dakota during the Spanish flu epidemic, and the courageous action of public health officers, nurses, and physicians, a number who died of Spanish flu. And we are in historic times now. And what you do and the actions you take, people will look back to this time and what we did and what people did with the opportunity that they had to fight this deadly virus. And I encourage you to recognize the importance of what you can provide our state.
Thank you.
Thank you, Dr.
Can I
McDonough.
ask an additional question, Dwayne?
Go ahead.
So when you talked about the risk categorization based on the 7-day average plus the mask wearing percentage, how would you measure the mask wearing percentage?
I would suggest that could be done by observation, much as you do seatbelt usage. It would be anonymous, it wouldn't be any punitive actions, but you could fund local health departments, law enforcement, whatever, to just go around and see what's going on and report that.
So I would challenge that we, as a committee, do not have the authority to spend money. So we could recommend the health department do something, but I don't believe that we have the authority to change some of the things on your list. I think we do have some authority, but I think that there's some things where we could just support the recommendation, but I don't know that we could actually implement.
Yeah, I don't know what the actual authority, but you have to direct the health department to do things or advise. Whatever you can do, I just encourage you to do it.
Thank you. Any more questions for Dr. McDonough?
One last thing to the faces I see on the health department, who I used to work with. Thank you so much for what you're doing. I know you've been busting your asses and you have an overwhelming workload to do, but I thank you for what you're doing and what you'll do in the future. Thank you.
Thanks, Doc. All right. Keeping those thoughts in mind when they're relevant further down the agenda, let's make sure we don't forget what he said. He's got a long history with the health department and is very respected, I think. And I've also received feedback from a number of people asking us to listen to Dr. McDonough. And so I think knowing what sort of support that he has in the community and the voice that he has in the medical community as well, I think carries some weight. So I appreciate your thoughts. They're well thought out. And I, much like Councilwoman Roars said, some of the things that we're capable of doing might be more advisory or recommendation as opposed to directive, but we'll sort that out. Thank you.
And you can just call me Kristen. I'm not here as a senator. I'm just Kristen today.
Okay, we'll move forward with the agenda. Brenda is up next on budget discussion coming into the legislative session.
Yes, thank you, Chairman Poole. Clint's gonna present my slides for me in Drive so I can focus on the discussion, and they were also sent out to you ahead of time. Just to do an overview, we actually began our budget presentation or preparation. We do that in the summer. So the summer months were heavy with COVID, purchasing, procuring, things like that. But also the team worked together to put forth a budget to accommodate the governor's recommendation for general funds, managing our special funds, and then bringing forth the efforts best as we could within those criteria or limitations. So next slide. So in our budget strategy department-wide, we had to meet an 85% budget guideline with the general fund. And in all areas, we really sat back and looked at this to see if we couldn't do this with knowing all reductions would create some level of hardship. We minimized harm and impact to the overall funding, which was our primary goal. Also knowing full well that while we had a 15% reduction to make, we also had to absorb increases that might have occurred in operating, such as renewals of leases, which had inflationary factors in them, other things with supplies that we might need to continue to purchase that also have inflation tied to those costs. While it might be minimal, there was things like that that had to be taken into account and held within that 15% reduction as well. And then with the state employee increases that were granted in year 2 of this current biennium, there's funding in this budget for 1 year of those increases. But when we would develop the budget for 21-23, we have to include 2 years to fund that increase because they'll continue to receive that level of pay for 24 months versus the 12 months in which it was granted. So we also accounted for that and made sure that that was included in our budget request forward. This time when we prepared our budget, we also were notified by OMB that there were select grant programs that were actually excluded from the 15% general fund reduction, that being state aid to local public health. So the amount that they receive from the general fund is $4.7 million, and that amount was actually exempt from the reduction. And then another large general fund use in the agency is the Rural Emergency Medical Services grants. And those were also exempt from this reduction, including the training grants. So in general fund, that was $6.6 million that was actually excluded from the reduction. Next slide, please.
So I have a question for you, Brenda, over that. So it's a 15% level reduction overall, and those programs are exempt from it. Does that mean that it's a larger percentage reduction for those other programs to make up for it, or is it just those are excluded and 15% reduction only applies to those other programs?
Chairman Poole, I didn't quite hear you. There was someone that joined. I don't think the mic was on mute, and so I heard a lot of background noise. I think that could you ask your question again? I'm sorry.
So the 15% exemption for those 2 programs, does that mean that there's a higher percentage need to cut in other programs, or does that mean that those are just excluded from the 15% reduction? There's a 15% reduction to all of the other programs, and those don't have to face a reduction.
Right, it's the latter. So when OMB issues your general fund reduction target number that you have to hit, what they'll do is they'll take a look at your total general funds in your budget and then remove those aspects to come up with the reduction you need to make. So then it's absorbed within the other areas. So our reduction was approximately $3.7 million in general fund. So those were taken off the table before the computation. Did that answer your question?
Yes.
Okay. And so next I'd like to go in to what our strategy was and where the reductions were actually taken. We looked at our tobacco program, and that area was actually reduced by 1.1 million. That is 8.6% of the program. And while we are not suggesting an increase at all, but studies have shown that the most effective means to reduce tobacco use is to increase the tobacco tax itself. And that program is still funded at $11.8 million. It was 12.9. So one of the larger programs, and we looked at that area initially. Also in the budgeting process, we are allowed to submit what are called optional adjustment requests, and I'll get to that a little bit later. But we did talk about the tobacco program and did request a restoration and some additional funds for that area, and I'll cover that a little bit later in the presentation. Under our loan repayment program, That actually was reduced by just over $800,000. And we understand and we can fully demonstrate the benefit of the program, but where we're sitting right now with state revenue, we propose not entering into any new contracts under the loan repayment program in the event that we would have to make reductions during the session and during the biennium. So we are moving forward with the contracts that are currently in place, and our budget does include our obligations of $1.5 million to those individuals that you have approved in the past. We are just taking a hold for this biennium until revenues catch up and until we're able to actually put that those numbers back into a budget and make a request. Again, I'll cover the optional request. We did request a restoration of some funding for that program. Our fetal alcohol program was unfunded through this effort as we look. Oh, I'm going to stop there for just a minute. There looks to be a question.
If Chairman Poole, if I might ask a question, this is Daryl. So I guess there's an observation. First of all, this is a starting point for budget, and certainly during the legislative session, there will be additional comment and input for this. But with the public health funding, are you then proposing that it stay the same as it is right now? And the reason I asked that question is just wondering, they have been taxed with a lot of additional work in public health, and wondering if there wouldn't be a need for additional resources for public health. The other thing I just want to comment on too is the loan repayment program reduction. I understand that there needs to be decreases to here and there. But the concern I have is healthcare workers are extremely taxed right now, and we're yet to realize what those impacts of COVID will be on healthcare workers. And I think just to provide comment, I think it's important to continue that loan repayment program because more and more will need additional healthcare workers into the system.
Yeah. Thank you for those comments, and we certainly appreciate the feedback and the support from our Health Council. The decisions weren't easy, and so what we looked at, like I said previously, is looked where we could minimize harm and actually continue what we have in place and go forward. And I will cover for you later too an increase we did request for public health funding. So that is reflective. Going back to the fetal alcohol program, we took a look internally in the agency to see what our objectives and our priorities are, and we are always vested in aligning our programs within the state, working as one government. And the fetal alcohol program really was a pass-through for us to provide to the program up at UND and is better aligned with behavioral health. Now, fully understanding that Department of Human Services and their behavioral health division also have the same struggles and the same priorities that they have to go through themselves. And we did work with them and let them know that we were making this change. I do want to make you aware that this is a program that is supported by legislators from the years past, and they've been in contact with me as well. Again, we looked at it from a perspective of what are the priorities of the Department of Health, the public health, and knowing that this aligns better under a behavioral health atmosphere, and also knowing that we don't have an opportunity to find or attract federal funds for this program where they may have better opportunities at the Department of Human Services. The next reduction we looked at was reducing temporary salaries of $50,000 in the food and lodging division. And we were able to make that reduction because actually the governor's office added an additional FTE into that program last legislative session, and it was supported by our legislators. And then also trying to look at things not just from a mere reduction standpoint, but also are there other funding opportunities that are happening within the agency that would allow us to use less general fund and access additional federal funds for that offset. Two of those areas are in the Division of Life Safety and Construction, the plans review area. We were actually able to utilize some carryover revenue from the 17-19 biennium that ended just over about 14 months ago, and that'll offset our general fund need. That amount was just over $300,000. And then another area is the indirect rate in which we apply for with the federal government or submit to them for their approval. our indirect rate with the removal of the Department of Environmental Quality from our denominator, our indirect rate or our administrative costs, that percentage has increased, and that has allowed us to use additional federal funds for our administrative costs, decreasing then our general fund need. And that amount was just over $1 million. So the next slide, please. So this graph shows for you, just to give you an idea, our budgets are approved at a line item level by the legislature. And on the left-hand side, it shows the breakdown by the line item, the salaries and wages, operating, the capital assets. So this would be like our bond payments, large pieces of equipment, things over 5,000, and other extraordinary repairs that might be needed out at the building we own at the lab services area. It also has our grants line item, then our tobacco line item where I talked about the reduction, and that's where you'll see just over $1 million reduction in this area. That is a separate line item and is monitored from that perspective. Our WIC food payments are also a separate line item, and that's reflected for you, and then our total budget. So what you can see is our budget overall is flat, but we had some adjustments between the line items. Our salaries and wages are up a bit by just over 3 million. And then our operating is down by 3 million. And that is related to the increases I talked about earlier, some staffing adjustments, some temporary staffing we have requested within this budget request due to additional federal funds we've received. And then it's offset by some reductions we have made in our operating. In order to accommodate some of those inflationary increases, we had to make other decreases to meet the general fund target and absorb things. Grants are fairly steady. I've talked about the tobacco, and we have increased our request for WIC food payments ever so slightly by 120,000, thinking that the current conditions might have a slight impact on that number. If I can have you go over to the right side of the slide, that's where we actually talk about the general fund, the federal fund, and special funds, which make up the funding for the budget in total. The general fund reduction, of course, is attributed to the 15% reduction, and that is down just 3.8 million. So that would take into account some other smaller changes that were made. And then the federal funds, I talked about additional funding coming into the agency. That is approximately just over 3.7 million. And our special funds are held even. The special funds includes any private foundation grants. It includes any fees we're collecting for vital records, life safety and construction, food and lodging, any licensure we do, and some fees we do collect at the lab services area. And then on the far right, you'll see the budget being fairly static, just an ever so slight increase in our base budget request. So next slide, please. So to give you a visual of what that looks like percentage-wise, on the left-hand side, our budget by line item, it just gives you more of a look as to percentage breakdown. In comparison to our current biennium that we're operating under, outside of the increases we've seen for COVID, so this is just a comparison to a base budget from now, what we're operating now to what was requested. The changes are in the salaries and wages area. This time around, it looks to be 26% of our budget. In the current biennium we're operating, that number was 24%. In the area of operating expenses, that was previously 20%. That has dropped by 1%. And as you would imagine, over here on the left, the tobacco prevention control program in the agency was previously at 8%. And then all other areas are the same percentage as you see on this little donut chart. And then on the right-hand side, we actually want to give you a visual as to what our funding looks like from general, federal, and special funds. And there's a shift here also. In this current biennium that we're operating, the payroll, or the general fund was at 23% right now in this biennium, and that will drop to 20% if the budget is approved at this level, at our base level request. And then the federal funds have shifted by the same 3%, previously 64%, and that is now reflected in the base budget at 67%. So next slide. This is just a layout of our optional requests that were made. They're called optional adjustment requests, and we are allowed as an agency, as I said previously, to submit items that are needed or that we see into the future that we would need in the next biennium that were not able to be reflected in our base budget request. Our first priority was, and these are in priority order, and our first priority is COVID-19, and I'll talk about that in detail, and I'll just cover the others here. For our local public health state aid funding, this has been relatively flat, and we are making a request of $5.2 million for the local public health to do their work. Our team did a survey of local public health, and their focus is related to communicable diseases with vaccinations, and then also chronic disease as we move forward to make North Dakota the #1 healthiest state in the nation. The next request is a one-time upgrades in our forensic examiner office. That is comprised of 2 items, an electronic record system for $410,000, and then an overall body imaging system for $500,000 that will decrease the time where we could do 1 image instead of multiple x-rays. So that is a one-time request of just under $1 million. I had talked previously that we would be making a request for additional funds being put back into the tobacco prevention and control program, and the effort would be really tied to media efforts and cessation. There is documented data that shows that additional media results in additional calls into the North Dakota Quits line. So we have requested of that amount, we're requesting $1.5 million related to media. The CDC recommends for best practices that actually we would spend $1.3 million a year for media and education that would run. Right now, this budget contains $108,000. The next area is loan repayment, and we do realize the significance of this area and the importance of this area, and it gets really tough to start prioritizing one over the other. The loan repayment program would allow for what you've been used to seeing this biennium, and that would be 3 slots each year of the next biennium for dental, for physician, for the advanced practice individuals, excuse me, and then also 2 for clinical psychologists, and then 6 for behavioral health. Also in this number is the 3 slots for the veterinarians, and we do that on behalf of the Department of Health, and you approve those for them. So those are the slots that are included in this number. For the forensic examiner area, we've also reflected a request for an increase in their contract. We have been partnering with them for many biennia, and we did receive a proposal from UND. It was the last week of July, and then knowing we had a budget deadline in mid-August, and mid to late August, we had a couple of deadlines. So the proposal they provided to us would substantially increase funding for both areas, both at UND and the Department of Health. With the fact that Dr. Barry Miller, our forensic examiner, has just joined us in July, and the fact that we do have a public health strategist that was appointed by our governor to do a plan and take a look at things, rather than moving forward that plan, we felt it was more important to have a discussion to see what the public health strategist had before us and what they were looking to present. And then instead, we have proposed at this point in time a 20% increase in the amount we provide monthly to UND to help us with the counties on the eastern portion of the state. Then the final 3 optional requests really relate to temporary employees, long-term temporary employees that we have had in the agency and have needed that staffing level. It's the cost to convert them to regular FTE. The costs are actually rather minimal from a standpoint of adding 8 additional FTE, but what the costs are to cover the cost of fringe benefits, basically the amount that's paid on their behalf to the retirement. And so we are providing health insurance for those individuals after they've been with the agency over a year. And because of ACA, they are entitled to health insurance coverage if they work more than an average of 30 hours a week. So that rounds out our optional requests other than COVID-19. And so if you go to the next slide, we can cover our number one priority. So as we developed the request for our activities related to COVID, remember we started building this back in July. We started looking what was before us in July and early August, and that was where we were seeing some increases in caseload, and didn't have the vision, like many of us wish we did have a crystal ball, but we didn't have the vision to know what we would be seeing in November or December. We built this budget based on what was in place then, based what was available to us as testing mechanisms. There have been new testing opportunities presented to all states, that being the Buy Next Now. So when this was submitted, things have drastically changed, like everything else with this pandemic. Things change daily, things change weekly, and then they also change monthly. So what we've submitted and what I'm presenting to you is what was our look at this back in August, and then rounding up some discussions with OMB into the month of September. The lowest parts of that, or the lowest percentage of that, would be in our health analytics area. It's adding staff there. And I'll go into some high points on the next slide, but just want to briefly talk about what these include. Our health analytics are assisting with the dashboard, getting information out there from a data-driven perspective. The fiscal communications and HR team, that consists of 4 individuals. And what's happening is, as you can imagine, as we bring in 12 additional funding sources, so not only did we receive funding from the federal government for what's called coronavirus relief funding, we also have some FEMA funding, and we had 9 to 10 other federal grants that came through the CDC or other state federal agencies that provide additional funding for the agency. On top of that, we have added an astronomical amount of temporary employees to carry out the mission. And I believe last month we processed over 900 timesheets. And so we went from an authorized level of 205 FTE to operating with payroll of just over 900 each month. So things have really ramped up quickly for this agency, whether it's human effort or with the technology at the lab. Multiple individuals added for the case investigation, contact tracing work that we're doing, and then everything else behind the scenes with what our leaders in the agency are doing for us. The other category, the 3%, is our outreach response and public health hotline area. Noridian is helping us with the hotline as well as our team members here. We also have stood up a specific area for outreach and response where they are helping with the testing schedules and the collections out in the state. The lab workforce and related cost is 7% of that request. And that, I think, just speaks specifically as to what it is what we've needed to do at the lab. We have gone from doing 200 tests upwards to, some days well over 8,000. I believe we've reached 10,000 at a time, but we operate at a 24/7 environment rather than an 8 to 5. And that was ramped up very quickly, as I'm sure many of you have seen in the papers and discussions and press conferences. The next area would be the area that is headed up by our emergency preparedness and response area, where we have our warehouse handling our PPE and other medical cash, and our department operations center. That comprises 8% of this request. And then local public health, we know they are boots on the ground. They help us move through this pandemic and do the work out in the local communities. 11% is attributed to that area. And then I talked about contact tracing, case investigation. We have vaccine work we're doing and surveillance. That comprises 14% of our budget. And then the predominant cost, of course, would be our testing cost, the cost for the actual testing itself outside of the human effort or the salaries. So next slide. So this slide for you just outlines the major cost components that are reflected in that pie chart I just walked through. Again, testing supplies, it lays out the testing strategy for a period of time starting with July of 2021 and then finishes at the end of June of 2023. And again, remember, these numbers were developed in the late summer, and a lot of things have changed. So we do know that as we go to the legislative session, we will see what was actually authorized, if anything was reflected in the appropriation for the Department of Health. And then we will continue to update those numbers as we move through the legislative session, as I think things will continue to change. We've included funding for all true NDSU and UND to help us with some testing, and then also some funding for a reference lab when we have to send things out of state. Another big cost category for us was the FTE, and this reflects 143.5 regular FTE. It gives you the breakdown by the areas. The 4 I mentioned in fiscal, communications, and HR. We have 8 in health analytics, 42.5 FTE in lab services. The 0.5 is our CLIA director. And then 60 case investigators, surveillance, work in the area of disease control division. And then 8 department operations warehouse team members. And then the area of outreach and response I mentioned includes 21. So then we also have reflected temporary staffing, knowing that we're going to probably start at one level, as you can see in the testing, and then some of the work will hopefully, as everybody hopes, will decrease over the biennium. So we have included some temporary staffing that we feel will be necessary. A communication specialist for the first year, the 150 contact tracing case investigation folks decreasing over the biennium. We're going to need temporary help in lab services until we figure out, as we decrease testing, how does that work in our lab services section. And then overall in department operations, that'll decrease over time, but that'll be our effort from the Medical Reserve Corps that will go out and assist long-term care, assist other facilities when their staffing needs are low, assist with testing across the state. And that's the area we have reflected the cost for that. Overall, that is $58.9 million. And then some other things that I wanted to point out are the fact that we have a media and education campaign built in this request of $1 million. We also reflect travel costs, our courier services for transporting the lab specimens, or even PPE, and additional warehouse space that's needed because of the increase in medical cash and the PPE we're handling, and that at $3 million. Our public health hotline contract, we feel that there's going to be continuous calls, and that is continuing to ramp up. And so $3.2 million is reflected in this request. PPE I've mentioned a couple of times, and that shows you the amount reflected in this optional request. There's also technology costs that have to be taken into account. We have set up various systems to handle the contact tracing, talking test registry, talking from one system to the next. 6.8 million is reflected for that. And as you saw, as a separate slice of the pie chart was local public health, our boots on the ground, for 30 million. So that concludes, in a very high level, the budget request we submitted, along with the optional adjustment request. We should be able to have some feedback when the governor does present his executive budget the first week of December. And then we'll have a better idea what our budget looks like. And then we'll adjust accordingly and move forward in that fashion. We do testify before the Senate this year first. And then after that, of course, there's the crossover, and then before the House. So I imagine we'll continuously be updating what's happening and reflecting those numbers as we move through both the Senate and the House, and try to figure out, without the availability to access a crystal ball, just what it's really going to take to make it through the pandemic, which will, in everybody's mind, extend into the next biennium. So, Chairman Poole, that is what I have for you today. If there's any questions, I'm open to those.
Yeah, I guess I'll start off with a comment, or maybe 2 comments, and then open it to other questions from the rest of the membership. First off, it's a smaller dollar amount, but I think it's something that really needs to be very clear, in that we're asking for a 20% increase for UND for the forensic medical examiner, where that 20% increase was proposed by a UND employee. I think we need to be really clear that in the operation of that role, why that increased need is there, and document it, just because to me, I never want to see anything that even sniffs of conflict. And then second, the idea that our state health strategist is apparently very influential in where this budget is going. I think leads to the conversation of whether the health strategist should be engaged in the health council.
That's a good comment.
Comments. I'll open this up to the membership for additional comments or for Brenda to respond.
Yeah, Dwayne, if I could just say, I just want to clarify on the forensic examiner contract, that increase was what we proposed as an agency. It didn't come from them. They came forward with, I believe it was it was just over $3 million of a proposal to enhance forensic examiner services across the state, both for UND and considering the Department of Health. We realized, for the reasons I stated, that it's not the right environment and time to bring that forward, especially with Dr. Barry Miller just joining us in July and not having an opportunity to really understand the system and see what she would make as recommendations. So we brought forth that increase.
Okay.
Because we have not increased that contract. There hasn't been regular inflationary increases provided to that, except this current biennium. We did work with them on providing a slight increase over the appropriated amount. So just wanted to clarify that.
I appreciate it.
And thank you for your comments regarding Dr. Wynn. I appreciate that.
Brenda, do we have any statistics on what the tobacco tax is in North Dakota compared to Minnesota, Montana, South Dakota? I know it's ridiculously high in these other states.
Sure. Dr. Wolf, I will reach out to our tobacco team. Neil Sharvett has that information. I don't have that readily available, but we will make sure to get that sent out to you.
Yeah. Thank you.
Yes.
Brenda, you had made a comment earlier that tobacco taxes actually have a strong response in terms of a reduction in tobacco usage. I've been involved in several of those studies historically, and you are absolutely correct that, and it not only has an impact on usage, it has an impact on usage in specific demographics more than others, and more so than anything else, increases in tobacco taxes affect recruitment of younger smokers more than it affects adult smokers, which is really where, from a public health perspective, you want to interject public health policy is early on in the process.
Chairman Poole, if I can ask a question regarding the COVID budget. FTEs of 143.5, Brenda outlined in that area. Are these FTEs that are currently, or a portion of these are in your current budget that you're looking to continue to fund the next biennium, or actually newer positions you're looking to incorporate?
Yeah, thank you for the question. To clarify, these are folks we already have in positions doing the work for us. And I think we needed to look at, first I have to say that I do think from a workforce perspective, before the pandemic, we were very trim, we were very tight, we were very sync. There we go, got it. And I do think that we weren't positioned at all to react and work through a pandemic with the staffing we were at with 205 FTE. So bringing these individuals on and working and talking to OMB about the request, it may be that some of them might truly need to be here for 24 months. Might that change? And that's why I think we have the opportunity to present budgets every 2 years, to look at what our needs are every 2 years. And at this point in time, when we developed this really demonstrated to be our need. And then that, again, we'll see how we go through the session and then reevaluate that when we have the next opportunity to develop a budget.
Okay, thank you.
This might actually be a dirt question. Is there a plan for scaling up and scaling down of staffing as related to this and other external funding?
Thank you for that question. That's sort of what Brenda's been talking about is there is an immediate need come December 30th, not 31st. Our CRFS funding runs out. And so we need to start having a de-escalation plan in case funding's not improved. We may need to shift how we're proposing our funding. Obviously, the legislature has distinct authority on what sort of funding we have available to us. So if we're not going to get the amount that's requested, obviously that changes how we can respond to the pandemic. These are all things that we are analyzing and working through. We're also working through what happens if the National Guard needs to change their federal orders. There's all these different planning activities that are happening kind of in unison with sort of a cliff that happens in December 30th. We do have planning activities established, de-escalate and to escalate depending on what happens with the funding sources. But it's a constant battle, it's a constant target, and it's constantly shifting and changing depending on resources and need.
Other questions? Other comments? Thank you, Brenda.
Yep, and thank you for the opportunity and for letting us have the opportunity to present what we're looking at for the next session.
See, so the next thing on the agenda are the COVID updates. Who from staff is going to start us off on those?
We have found out.
Yeah, good morning. I don't know if Dirk wants to start or if he wants me to start. So,
Go ahead, Kirby.
all right, thank you. Thank you, Chairman Poole and Health Council members. There are several individuals on today that will provide updates. Dr. Mason, Tim Wiedrich, and I don't know if there's others there, but I'll just give a quick overview of what's happening from disease control and forensic pathology section. And I just want to give a shout out to Brenda too, because we put together a budget in a difficult year where everybody who's usually is able to help out a lot with helping to get that budget thrown together was distracted by responding to COVID. And so she didn't get the 100% attention of the people that usually are there to help out more. And she did a great job of pulling that all together. And so we really do appreciate the work that she did for us on that. I just want to give you a quick update on the things that we're working on. Disease surveillance, which is one of the cornerstones that this response and being able to collect that data. I think our new challenge is with the antigen testing and not so much the laboratory-based antigen testing that can occur where laboratories who are used to reporting to us continue to report to us. But I think the challenge has been with the expansion of the Binax test, that truly being a point of care test that can involve testing in non-traditional places. That has presented some unique challenges for us in terms of making sure that we can get those test results reported. In the long-term care facilities, we think we have a long-term solution with those CMS certified facilities, which are our skilled nursing facilities, reporting through the NHSN. That's a platform that is used for healthcare associated infections. The CMS has required that the CMS certified facilities report to the federal government through this platform. And so that the good news on that is that we can take in a message from that platform as well and into our disease surveillance system. And so that electronic message can come through that platform into a different platform at the federal level and then into us. And our understanding is that we will get reports several times throughout the day from that platform. I think the challenge now is we got to make sure that our skilled nursing facilities get registered to use it. It requires a higher level of security. So they have to go through a process to get to that security level. But once they get through there and they get their training, we should be able to get reports through that process. Until then, they continue to report to us, focusing on getting the positives reported to us, but eventually we will be receiving both positives and negatives from the facilities. So we're continuing to work on that and getting those reporting things squared away. Skilled, that's skilled for basic care and assisted living. Those present some other challenges. Those facilities will have the option of reporting through NHSN, but there are other options that are available, and we have put together a spreadsheet that would allow them to submit data to us electronically through a spreadsheet. It's a short-term fix until we can get something better. We're also working with healthcare standard, because we understand that both of the basic care and the assisted living facilities are familiar with healthcare standard. So we're working with Tim Weidrich's group in EPR to put a module into healthcare standard where they could report through healthcare standard. We're also looking at, there is a private firm at the national level that has a platform in place that might allow us to digest an HL7 message, which would be ideal for us, because even when we get a spreadsheet in and we can import that electronically, that will be still a manual process. If we can get fully automated into an HL7 message, then that would be ideal. So we're still looking at that option there, and we're exploring a different option that as well as that other states are using. So we're exploring some other options for long-term solutions for reporting out of the assisted living and basic care facilities. The other part of this is that reporting out of outpatient clinics and some of our critical access hospitals where these tests may be used. Many of the critical access hospitals do have electronic laboratory reporting, and they report to us directly electronically, are able to send us an HL7 message, but some of them do not. And so, some of the things that we've talked about here may be used for the critical access in the outpatient clinic settings as well. And so I think the idea here is what we need to get an efficient system together. Reporting, we don't want reporting to be overly burdensome for the reporter, and we don't want it to be overly burdensome for us to be able to digest that report and get it into our Maven system so that our disease investigators can access that data as it comes in and they can start their investigations. So the other part that I wanted to talk about a little bit is the case investigations, and we continue to build our team.
Kirby?
Yes, go ahead.
Before we shift subjects, can I ask a question over the testing that you were just talking about?
Yeah.
And the level of false positives in the testing that you're talking about, is there a procedure in place where, especially considering staffing shortfalls at medical facilities, where you actually do some sort of a confirmation testing to make sure that you're not isolating or quarantining a healthcare worker for a false positive?
Actually, when we look at the data and we look in the little bit of evaluation that we've been able to do in the state, and when we look at the data from other states and from the FDA that the company submitted, the specificity of the test is really good. And so the positives really do, there's a high level of concurrence with PCR with the positive Binax test. It's not 100% obviously, but it's very good. And so our bigger concern is the potential lack of sensitivity that where we're going to be missing cases, especially in asymptomatic individuals. And so I think that becomes a bigger issue in our mind. So, yeah.
I was hoping that was what you'd say.
Kirby, so between being on the Health Council and being in the legislature, I get a lot of really fun emails. And so I'm sure you do as well. So one of the things that people, consistently bring up is the PCR cycles. And, I don't want to feed that beast, but I feel like the lack of an answer sometimes feeds it more than just responding and saying, we use these 3 machines and this is the number of cycles on each machine, and just put it to rest.
Yeah, and I think Christy Mason really can respond to that. Dr. Mason, I'll let you pop in here.
She's raising her hand.
Yeah.
Yes. So, this is where one of the things too that we've talked a lot with our communications folks is how to message this, because when we start to talk about CT values, you're really starting to peek behind the curtain if you will. And so all of these tests were designed by, the incredibly smart scientists at all the different manufacturers, and everybody's just determined to see a CT value. But really, we actually don't even see the CT values in the lab because there's interpretive software, because the manufacturers established a parameter, they submitted it to FDA with these parameters. And yes, the higher cycle thresholds you use, the more likely you are to pick up junk and have some false positives. Of course, that's innate in every test. The other problem is that we use multiple platforms and they all don't give CT values. Some give a cycle number, some give a relative light unit, and some don't give us anything. We can't even peek behind the curtain to see what's back there. So it's really hard for us to give a straight answer because we're running such different platforms. So if I speak specifically about the CT values, I'm giving you just one platform. And a huge percentage of the people that are tested in my lab might not even be used on a platform that I answered the question for about CT cycle. So it's really complicated for us because we don't have just one. In fact, we have two instruments that both use CT cycles and they have different thresholds. So it's hard to give one because I've got a CT value cutoff of, for example, 37 on one and 40 on another. So I know that just muddies the water a bit, but that's why you're not getting a straight answer out of us.
Yep. So then how do you respond to people who, respond that 37 and 40 are significantly higher than what some research says you should be utilizing? Obviously you have to follow what the machine does, but how do we help message the response from us?
Yeah, and that's actually why we're working with our communications team, is to try to explain that a bit to those that are not from the laboratory, because it's hard to explain. But yeah, so where I just try to stand is that we follow the manufacturer's guidelines. The manufacturers got FDA approval. They vetted their own systems and their own processes and procedures, and we do not deviate from that because we open ourselves up to interpretation risk, when we deviate from this established protocols that have been approved by the FDA.
So can you just help me understand, like at a national level, whether it be from manufacturers, from HHS, whatever, work happening to try and, I don't know whether it's find a test that isn't a PCR, narrow this. I get so frustrated with this. And so I just want to know, is there work happening to find another test that people can be more confident in? Or
well, the problem is that PCR is the gold standard. So PCR is the best test that we possibly can give you. But I think where people struggle is they want it to tell them something that we can't necessarily tell them. So for example, they want to know if they're infectious. Well, a PCR specimen can't tell you if you're infectious, but I can tell you if you have viral particles or viral remnants within your specimen, right? So does it mean you're actively infected? Maybe. Does it mean that you were infected recently and now you've got dead viral particles that you're shedding? Maybe. Does it mean that you're symptomatic? Maybe. And so I fear that there's a lot of demand on PCR to tell people something that they can't. And a lot of it's relying on, are you infectious? And that's not something that the test can necessarily do. The test that can tell you that is viral culture, and that takes several days to do. And it's not the most reliable because what then you're looking for is live virus that will replicate. And we're putting that into a tube. We let it incubate. We look for changes, and then we confirm what virus is actually inside the specimen. So now all of a sudden your 24 to 48 hour turnaround time on PCR is looking like a week. And a negative isn't helpful because the virus might be active in my body and is active when it's collected, and I might be infectious, but by the time we collect the specimen, put it in the transport media and send it to the lab, it might have died. And so then the negatives aren't helpful either. And so that's why we rely so heavily on PCR, is because it's sensitive and specific enough to find the RNA in this particular case within the specimens, and it does it well, but it doesn't tell you if you're infectious. And I think that's the argument, is a lot of people want to relate the infectious risk, if you will, with a PCR CT value. But again, that CT value is not something that's utilized. It's not the test is qualitative in nature. So it's looking for a positive versus a negative. It's not giving you like a viral load that's quantitative to say this is how much virus you have present in your specimen. So, I mean, maybe with further research, I feel like we need more research out there that's driven towards what CT values or what viral loads, because really CT values aren't going to give you a viral load. That's a different test. But let's say somebody can create a quantitative PCR so that we can look at viral load versus symptoms versus infectious rates. But, that'd be a pretty big long-term study where we looked at, a new test against culture and against infection. And I think the problem that we ran into in this current situation is that the universe imploded and we needed something to tell us. And so just looking right for viral RNA in this case was the best option.
Yeah. And that's why I was trying to figure out, just as we've gotten further into this, has there been, I don't know whether, like there's the saliva test versus the nasal swab versus are those all still PCR?
Correct.
Okay.
Okay. When they're sent to us, they're all still.
No, I'm looking bigger picture than that.
Yes, there are, most of them are PCR. It's those point of care tests that are coming out, the Binaxes, those Solanas that are looking more for the antigen. Those are not PCR. Those are antigen tests.
So then, nurse, not lab person, help me understand, like when looking for antigen versus the PCR, like what's the benefit risk there, just to help me solidify that in my brain.
Sure. So what we're looking for is, the actual constructed viral particles, if you will, which are really great as a screening tool. So somebody who's very sick, actively infected, that test is going to work great on, because there's going to be enough going on in that person's nose at that point in time to test them and to get a really good answer out of. But the person who's on the upside of the bell curve or the backside of the bell curve in their infection rate, PCR is really good at catching this part of that. Antigen's really good at this part. And so what we want to do is when you're making decisions about vulnerable populations, like moving somebody into a COVID ward or things like that, I mean, you want to make sure that you're using the most sensitive test or the most specific test that you possibly can, because you don't want to risk taking somebody who potentially doesn't have the disease and putting them at higher risk by moving them into a COVID ward, or taking somebody out of a COVID ward and moving them, So when you're making policy-driven changes, you want to make sure that you're using the best test possible.
I just, in my dream world, wish we could come up with a like black and white, yes, you have it, or no, you don't, because this like, oh, well, you were in contact with someone and you now have to quarantine for longer than the person who was actually sick is very, very frustrating for people.
Yes. And that's why I think looking for, viral RNA is definitely the easiest explanation for yes, you have it, or no, you don't. Whether or not you're infectious is a little bit muddier.
I believe Dirk had his hand up.
My comment was what Christy said, is that we do follow the manufacturer guidelines, and we want to make sure that we're following what's been approved by the FDA. So she already nailed it.
Dr. Brousseau, your hand is up.
I just wanted to go back to follow up on something that you asked, Duane, and also that the definitions of a couple of terms have been being thrown around, and that's sensitivity and specificity. Now, for people who aren't really grounded in statistics, I think we do have to understand the difference between those two things. I think I know what they are, but maybe Kirby would like to define those for us. And you actually pointed out the importance of specificity. I was glad to hear that. Take it away, Kirby.
So you're really going to test me on my basic epidemiology here. So specificity, I'm not sure if I'm going to get this right, but when I look at specificity, that's the ability when that test is positive, that is really the higher the specificity, the more likely it is to detect and truly detect a positive when it's there. The sensitivity is, from my perspective, is the ability for the test to detect it, the individual, how well it can detect the infected population overall. When I look at sensitivity, if it's something 90%, we should be able to, that test should be positive 90% of the time when an individual is infected. Specificity, if the individual is not infected, it should be negative. So
That's
Is my test finding what I'm looking for, and does it find it very well?
yeah,
I think the specificity is the believability of a negative test,
right.
and the believability of a positive test. So we want a high specificity so we can be sure that if people test negative, they don't have the disease. And the problem comes in then is that as the specificity gets real high, the sensitivity may actually drop a little bit, but the sensitivity is the problem that Kirby was talking about, that the test may not actually be positive in people who are carrying the virus. So it's important to keep those two things in mind, I think, when we're talking about statistics and tests.
Right. And then when you look at the public health application of these tests, you look at the prevalence of disease, and you end up with positive predictive value and negative predictive value, which are also important too. And yeah.
Thank you.
I think that leads back to the messaging question that was asked, and that is the idea that we feel really confident in the idea that somebody who's been tested through our system as a positive is highly, highly likely to be a positive. The question marks come in those who slip through that are positive and are identified as negative.
Correct.
Okay. Sorry, Kirby, for derailing you in the middle there.
Hey, no, that's good conversation. And so from just a little bit more from my perspective, I just wanted to update you on our case investigation and our caseworker team. We are continuing to hire. We will be hiring another 57 or so individuals. Some of them have been hired already, but we're in the process of finishing that hiring process to bring them on to supplement our caseworker team in disease control. We continue to work with the universities. There's contracts at 3 universities for caseworkers. And between the 3 universities, they have, I would say, close to 200 individuals that have been hired. And so that's going well. Local public health, they continue to do contact tracing. Both Grand Forks and Fargo-Cass have teams devoted to case investigation and contact tracing, and so they continue to do the majority of work for those counties, and that's good. And we continue to work with the National Guard as well. They have about 60 individuals that are helping us and assist us as well. But Dirk mentioned, that we do have to look at how long do we continue to engage, and we have to be ready if the National Guard needs to engage elsewhere and they need to pull teams. We need to be able to make sure they're ready to cover what they're doing for us, and so we're working on that as well. I think that the other part that I wanted to mention is with local public health. They are being pulled in a lot of different directions. And so, as the vaccine becomes available, a lot of them will be prioritizing their work on vaccinations. They're helping with testing. They are trying to get flu vaccinations done yet. Most of that we're probably past the peak on the influenza vaccinations, but there's still some of that going on. And then they're helping with the case investigation and contact tracing. So I think that they're just being pulled in a lot of different directions. And I think as vaccines become available and they get more involved in vaccinations, we may see them back off from some of the contact tracing. And so we'll need to, in case investigation, so we'll need to help out with taking over some of that load as well. In terms of the vaccine, there are 2 vaccines that are are nearing their end, are completing their phase 3 trials, and one is the Pfizer vaccine, the other one is the Moderna vaccine. We are anticipating that we could have vaccine in the state in early December, possibly early to mid-December. And likely the Pfizer vaccine will be one of the first ones. That is the vaccine that does have some fairly stringent cold storage standards. It requires ultra cold storage and handling. And so that one will be a little bit more challenging, but we are anticipating that, and Tim will be able to talk about this a little bit as well, but we are anticipating that that we will be able to distribute as we need to in the areas that we need to get it to. The idea is that we don't want to be the middleman in handling this, and the minimum direct shipment that will come from the federal government for the Pfizer vaccine, or from Pfizer themselves, is 1,000 doses. And so, initially their doses are going to be very limited coming into North Dakota, but if there are areas, our healthcare facility or an area that we can get 1,000 doses to, and they can use the 1,000 doses in the time frame that the vaccine will be good outside of that cold storage requirement, that's the ideal, But if to get out into the rural areas, we'll probably have to have that vaccine shipped to the health department, and then emergency preparedness and response, and will have to help us with breaking it down and getting it out. And they have done a great job of preparing to do that, even at the ultra cold level. So the Moderna vaccine is a frozen vaccine, but it's not ultra cold, and so it's just normal freezer temperatures, and so that will be a little bit easier to handle once that gets released. But we are anticipating that will probably come out maybe the second one coming out. So, and the good news is that both of those, the preliminary data on both of those vaccines are showing efficacy in the mid 90%. I think today Pfizer released their data that it's about 94%, and I think Moderna had 95% on theirs on a recent news release too. So that's the good news for both of those vaccines.
This is Jim here again, and then so compare that to the influenza vaccine, for example. What's the effectiveness of that in comparison to these proposed vaccines? Influenza vaccine could run anywhere from the mid 30s to 50%. So this is really something to have a 95% effective vaccine.
Both of the vaccines that I've talked about are a new type of vaccine. They're messenger RNA vaccines. And so this is a promising new technology, I think. And I'm hoping that this really works out, because, to have that kind of effectiveness is great. So.
The common flu vaccine is frequently associated with egg allergies based upon its production level. Are there allergies or other issues associated with the two vaccines that are coming out, or populations that might be precluded from taking them?
Well, I think that there's always a potential for allergic reactions in any of the vaccines, depending on the components. Neither one of these have egg protein in them, so that should eliminate that. But I'm not seeing any information that suggests that they're more allergenic than anything else that's out there. So,
Thank you. Any other questions for Kirby?
Chairman Poole, this is Daryl. I just have a question. Unless I'm mistaken, Kirby, there's kind of been a shift, especially in some areas where those individuals that test positive are being requested to contact those that they've been in close contact with, because just the overwhelming number of positives and the limited resources with contact tracing. Do you have any idea how effective that is being in those positives reaching out to those individuals that they've been in contact with?
I don't have any hard data, but I can tell you that on our public health hotline, on our COVID hotline, we have an option where they can hit option 2 to talk to a caseworker because they are either a close contact or they're a case and they just have some questions that they need follow-up on. And we are getting a lot of those calls coming into the hotline. So people are being notified. They're telling us they're being notified, and they just want to make sure that they understand how long they should be quarantining. And so that is happening. And I can also tell you that we continue to do contact tracing for K through 12 settings. We continue to do contact tracing in the healthcare settings with our healthcare associated infections team. And the university systems with those contracts that we have in place continue to do full contact tracing in the university level as well. So.
Okay, who would be next on the COVID updates?
We'll move on to Tim. Oh, Christy, you want to go?
Is it possible to take me next, Christy? If and Dirk, I do have people. I've got a
yes,
meeting.
Tim.
Yeah, and I got to get to that meeting right now, so I'm going to drop off as well. So, thank you so much.
So thank you so much for this opportunity. I just want to talk kind of about two things and then open up for whatever questions you may have of me. Let me just bring up a screen and let me know if in fact you're seeing my screen.
We see your screen.
All right. So first I'd like to talk about the personal protection equipment that's in the state medical cache and those inventory levels. I'm going to walk through the categories that are most prevalent with this N95 response. With this COVID response, leading off with the N95s. These are respirators that we started out with 1.4 million at the beginning of this event. We're now down to 431,000 of those. There's another 12,000 that are pending, but I'm going to kind of drill down a little bit of detail here that unfortunately this past week we had to cancel an order for 750,000. We've been trying very hard to get back up to our pre-COVID inventory levels as quickly as we can, but the types of product that would not require us to refit test the entire public health and medical workforce simply is not available. We're utilizing very heavily a product manufactured by 3M, as quite frankly is a substantial amount of the rest of the country. And the manufacturers indicating that we likely won't have quantities available in the levels that we're attempting to order until next October. And so if in fact this bears out, we will in fact be facing a challenge of bringing in a different type of N95 respirator that would require us to fit test basically the vast majority of the medical community, the public health community. Moving on to surgical masks, we're fairly comfortable with that supply, 2.9 million. Shoe coverings, we have another 200,000 that we're expecting before the end of the year, which will place us in a very strong position there. We have another 600,000 isolation gowns that are coming in before the end of the year, which places in a comfortable position there. I'm a little bit concerned about our gloves. And so while we don't have any actual pending at this point, that we are trying very hard to get that inventory higher to somewhere around the 3 million mark. Face shields we're in good shape for with 664,000 and then goggles at 17,000. So my two main concerns are N95s. And again, just to revisit that, the Battelle system, which is a hydrogen peroxide process for decontamination, that contract has in fact been extended beyond the end of the year. And so as we move into the winter past the 1st of January, we're expecting that capability to be maintained for multiple months so that we can in fact recycle or decontaminate up to 3 times the N95 respirators that we currently have. Let me go to one other slide, and that's to talk a little bit about the State Health Department COVID response team. You've heard a lot this morning about the temporary staff that's been brought on. This is the slice of staff that is providing direct services either to long-term care as their workforce needs to be furloughed because of COVID positive workforce. We then supplement with the staff from this response team to keep those facilities up and running. We do the similar thing for critical access hospitals, and we would also have staffing available for tertiary care centers as well if that became necessary. And so there's a wide variety of missions in addition to those types of direct patient or resident care, including assisting with testing, and a much smaller portion of this, literally less than 20, are engaged in the administration components to our emergency operations center. So we have 346 folks, 140 of those are full-time, 206 are part-time, and you can see that there's a variety of individuals that are part of that mix, including nurses, couriers, certified nursing assistants, the emergency certified nursing assistants, which I do want to just quickly mention is a program that's up and running that will be able to take, or does take, individuals that are new to the workforce as CNAs. So somebody that's interested in becoming a CNA and working in this arena, we have an accelerated program that involves a distance learning, a video-based or web-based portion that consists of 8 hours, and then an additional 24 to 32 hours of psychomotor skills, so hands-on type things. And then at the end of that process, those individuals emerge as emergency certified nursing assistants, which means they can function in a long-term care facility or in a hospital environment during this COVID response. But then in addition to that, if they want to make this a career, there's a challenge testing that we can afford them that converts them into a fully registered certified nursing assistant, and they would be able to continue on in that field after the COVID emergency. We are continuing to work on bringing in out-of-state resources, and there'll be more about that coming in the not too distant future. Let me stop there and see what questions or comments that you may have.
I assume you still have more, Tim?
I was just going to comment on the just as a closing, the distribution that Kirby just mentioned. I know that there's been a lot of discussion about the difficulties surrounding the cold chain distribution. Fortunately, we're in a really strong position. We've acquired the necessary equipment, both in the warehouse to receive the shipments in larger quantities, to break them down and then do the distribution. We have the portable ultra cold freezer units to physically do the transport and to maintain product in the field settings we're doing the distribution. Plus, we've acquired and are continuing to have as a resource the building of the capability to do our own dry ice manufacturing, which is an important component of being able to supply the various configurations that the shipping containers are coming in from the outside resources. So again, unlike I think many other states, we're I think in a very strong position regarding the distribution of this ultra cold.
So, Tim, one of the things that you brought up in the past, and I haven't heard anything on it in a while, but given the large number of people and the expansions that the hospitals are having to do to increase capacity, where are we on respirators, the ability to provide respirators to the facilities that are having to expand?
Yes, so that's been an ongoing situation that's being monitored. And if there is good news in any of this, it's the fact that the utilization of respirators has been far, far lower than what was anticipated at the outset of this. And so our monitoring and the feedback that we've got from the hospitals that there's not a concern over our ability to, given our current status and this much smaller percentage of people that actually need respirators, that is not posing a problem.
That's good news.
One of the few breaks we've caught.
Yeah, and then the other item that you've provided information for us in the past has to do with bed availability and specifically ICU beds for COVID patients. Where do we stand with that? And I know that that's eating people like Kristen's lunch and everybody else's lunch and expanding this stuff.
Yeah, this is a major issue, and we continue to see tremendous pressure on the hospital systems. We're publishing this information daily. So the snapshot for yesterday, so just so you're aware, the hospitals are reporting into a system what their staffed available beds are. There's two categories. One is for what I would call med-surg beds, or just general population beds. And then the other would be ICU beds. And so we collect that information and publish it about 1 o'clock each day. So I have yesterday's information. There were 179 beds within the staffed general beds within North Dakota, and 16 ICU beds. When you break that down by the 4 largest cities and where the tertiary care centers are at, there were 33 beds within those 4 cities and 10 ICU beds. And so this continues to be a very significant issue. The hospitals are continuing to manage, but it's becoming increasingly more difficult for critical access hospitals to find appropriate placement for patients to be transferred. And that in part is why we're doing a concentrated effort to attempt to bring in additional surge staffing from outside of the state.
Tim, this is an off-the-wall question, probably based on me having too much history with you and your program. Wasn't there a mobile medical unit that had like 15 or 16 beds that were capable of addressing some of these? Has that been deployed? That we got from Minnesota or South Dakota or Iowa or somewhere?
Yeah, so the short answer is that that is an asset and a resource that we have. But our model for pandemic has always been a little bit different than that, because unlike some areas, some states where the need is external to a hospital because there's not sufficient room in a hospital, our planning assumption as we work with the hospitals for the last 15 years has always been that we will run out of staff in a pandemic before we run out of physical space. And that's, in fact, the model that we're continuing to follow. So when I'm talking about bringing in outside staff, people from outside of the state and the work that's being done there, it's to supplement the physical space within the existing hospital system and increase the number of beds that way.
Thank you, Tim. Other questions for Tim? Tyler. I believe you're on mute.
There we go. Can you guys hear me now?
We can hear you now.
All right, Tim, when you're talking about the possibility of bringing in staffing, say we would use this mobile medical unit, or we had set up a makeshift hospital, is it actually possible to get outside staffing right now from other states or the Public Health Service or the Health and Human Services? Like, do we even have that as an option if we needed it?
So let me be clear about two things. One is that we're not talking about setting up a mobile medical unit. The staffing that we're bringing in would be to supplement the existing hospital system in their existing buildings, and then as opposed to setting up a tent-based or some other temporary structure as a hospital or as hospitals. And we are successfully and have successfully moved in securing a contract with an out-of-state labor pool. And while I don't have a ton of information to bring right at this point, because we just are in the process just have executed that contract, we're working very hard to bring them in as quickly as we can. And the same thing holds true specifically with your request or the question you asked, we have in fact made a request to the federal government, and that is also actively being pursued. And I'll have a lot more information in the not too distant future and very soon about those levels of staffing. But I'm optimistic that we will in fact get some level of staffing that will help with the situation.
Good question, Tyler. Any other questions for Tim? Hearing none. Thank you very much, Tim.
Thank you.
Christy. Thank you for being patient.
Oh, yeah, no problem. Well, hello, everyone. Again, I know I talked a lot already about our lab testing, but, here at our lab, we're working hard to increase our capacity so that we can provide as much surveillance to long-term care and the public as we possibly can. And to do that, and to address some of our supply chain issues that we've had throughout this pandemic, we've worked hard to diversify our platforms, which is why you hear me talk about multiple different tests. I feel like it was like playing whack-a-mole in the beginning, and we get reagents in for one platform, which would help us get through. And so we were constantly just battling the supply chain, which was a global issue, not just a North Dakota issue, but we're doing really well right now. We're sitting at a capacity at about 6,500 tests per day. We're able to turn those around in typically 24 to 48 hours. We do have blips where we do see some that are a little bit longer due to failed runs or instrument errors, or an increased test volume from the diagnostic world coming in from the hospitals. As we see more patients that are sick, we see more testing coming in from the hospitals. To offset the demand, because the demand is higher than what we have capacity for, we are utilizing outside labs like Mako. We're also working to bring on some partner labs like the North Dakota State University Vet Diagnostic Lab. They are just going to go live this week to help us with some testing on the eastern side of the state. So we're working really hard to just improve the test capacity even further here in North Dakota. Some of the platforms that we're running, of course, are the Cepheid Gene Expert, the Hologic Panther, the Thermo Fisher Amplitude, and the manual SARS-CoV-2 procedures, and the Abbott M2000 SARS-CoV-2 PCR procedures.
Thank you. Are there any questions for Christy? Looks like you addressed their questions already.
That was easy.
All right. Dirk, is there anybody else who will be presenting on COVID updates?
Yeah, we got a couple more. Nicole?
Brunel or Pesky? Sorry.
Brunel.
Okay. You want me to go over things when I discuss the research and response section?
Oh, yeah. Maybe we'll wait until that happens so we can kind of uniformly do that. That's good.
Yeah. Kim Mertz was going to go.
Okay. Go ahead, Kim.
Okay. Good morning, everyone. My name is Kim Mertz. I'm the section chief for Healthy and Safe Communities. And our section has been involved in many aspects of the COVID response. We've had staff that have helped do case management and casework. We've had staff that have worked at the dock. We've had staff that have done data entry. We have administrative assistance staff that have worked at the JIC and done meeting minutes. But the three things that I'm really going to highlight today is the public health hotline, the school response, and the results notification. So first of all, the public health hotline has been operational since March 12th, and this is the hotline that the public can call into if they have questions about COVID. The topics for the questions that are coming into the hotline, of course, as you can imagine, have changed greatly. At first, they were just very general. What is COVID? What symptoms should we be looking for? And those questions change depending on where we're at. So within the last month, some of the biggest questions we're getting have been from people that are trying to travel home, international travel. We had a lot of migrant workers that were here that were trying to get home. So a lot of questions. I'm working with Nicole Burnell and her team and others on making sure that, systems and processes are in place, and then that the hotline operators are aware of those processes so we can guide the public to the best places to get testing so they can get on those planes and get home. In the last week, what we've really been seeing is, test results, and that's actually been going on for quite some time. A large majority of our calls are from people that are looking for test results. And so we know that at times there are delays just because of various reasons, maybe with the lab, with IT issues. There's just stuff that happens. And so people call into the hotline and want to know, they're concerned they haven't gotten their test results. So processes have been set up to assist people with that. There is an online survey that the public can go to if they haven't gotten their results within 72 hours. We also have an email team that we can send results to if somebody does not have internet capability. So processes have all been set up for that. And that's part of the results notification that our section's been working on as well. And when I say our section, please know that all the sections just honestly are working like this together, because nobody does this in isolation. And we all have pieces of what each other is doing. So it's really just an all hands on deck and all teams effort up here, which I know you guys already know. So test results. The isolation and quarantine is also a question we get quite a bit. People are, they've tested positive or they're a close contact and they just don't know what to do. Even though we have caseworkers reaching out to the positive cases, and we do have a press 2 function on the hotline where caseworkers are answering that and can give information to, people are still just, they're anxious. And so even though they've maybe talked to one person, they're picking up the phone just because they need to hear it again and they need to hear a voice to talk to. So quite a few questions and comments on that. And then just recently, since Saturday, we've gotten quite a few calls on the new state health officer and the governor orders, as you can imagine. And people are calling anywhere from letting us know how maybe displeased they are with those orders, all the way to thanking the state health department and the governor for those orders. And then, of course, there's people that just have questions. They own businesses, they have dance studios, they run a gym, they work in a school, they just need help interpreting the questions. And so I think, as you can see, our hotline operators kind of have to be a jack of all trades. They kind of have to know a little bit about everything. And if they don't know the answer, they have to know who to direct the answer to. On a daily basis, the hotline receives anywhere from 500 to 600 calls, all the way up to 1,000. Monday this week was the highest call volume we've had since the hotline operated, with 1,001 calls. The hotline operates Monday through Saturday from 8 a.m. to 5 p.m. At one time, when all of this started in March, the hotline was operational from 7 in the morning to 10 at night. Then we've just scaled back, a little bit to kind of make things a little bit more manageable and with our capacity that we have. The one thing that we do want to let you know about is we're really very thankful for our partners that we have helping us with the hotline. We have a contract with Noridian Health Systems, and they have a team that are helping us not only answer the hotline, but also helping us do call outs for the results notification. I do have to give credit when Mylyn Tufte was still here with us. That was her idea. She reached out very early and said, Kim, I think we need to get some help and support for you. This hotline is going to be going on for a long time. She's the one that had the idea to bring Noridian on, and we just honestly can't thank them enough for their partnership. They're taking about 80% of the shifts right now, and then our health department staff is filling in the holes and working on the rest of that. So that's kind of, one other thing I wanted to share with you is that twice a week on Tuesdays and Fridays, we do send a summary forward of all the kind of major calls and concerns and complaints that we're getting. And then we do a summary of our call volume. I am more than happy to put the State Health Council on those summaries that we send on Tuesdays and Fridays. It might keep you in the loop a little bit about what the public is asking. So I'm seeing some head shake. Is that something that you'd like me to do, is add all of you to that summary?
Yes.
I see enough head shaking that I'd say probably yes.
Okay.
I do have a question for you, Kim, and that is over the results notification. You said that you're still trying to hit that target of 72 hours. So I have two questions. What percentage are currently being notified within that 72 hours? And I'd actually break that down by positives and negatives. And then second, you'd mentioned a survey. What does the survey actually trigger for the client on their end?
Yeah, Chairman Poole, thank you for those questions. I'm going to answer the second question first, and maybe probably have Nicole or Dr. Mason answer your first question. So the online survey, what it does is if somebody hasn't gotten their results within 72 hours, it asks them a series of questions. It asks them where they were tested, what their testing date was. It also has a feature on there asking them if they're going to be traveling internationally, so we can kind of flag those because we really want to be sure that while those aren't being prioritized at the lab, but we do want to be sure that if those results are sitting there, that we're able to go in and grab them. At the end of the survey, the person that's requesting their results does need to attach their driver's license so we can make sure that we have assurance that it's them that's asking for those results. And so that's our assurance piece. If in fact they are having trouble with that and don't have internet access or can't attach them, that's when we have the process where we send it through then an email system. So that's kind of how that works. But I'm going to let Nicole or Dr. Mason, I can tell you from the hotline that depending on what's happening at the lab or with IT getting things pushed out, 50 to 75% of our calls could be from people looking for their test results past 72 hours ago. And so, Nicole, do you have an answer, or Dr. Mason, to Chairman Poole's first question?
And I do not have the direct percentage in front of me. I know that Matt McKinney has some figures for that based off of the results just for the state lab. And I know that Shyla Thorson is working on identifying the different ways of gathering that data from swab to results. And working with the different labs that have the results coming in not only from state, but also from MACO. If anything is over that 72 hours, our goal is 48 always, and we hit that fairly often, but there are going to be some times where either the run failed and needed to be reran, or in regards to the MACO, we're having a lot of issues with the IT side of things and getting those orders pushed electronically over. So it can vary week to week when those results are coming back. So we're very lucky to be able to have that hotline available for those citizens to reach out so they can let us know that they are missing it or haven't received it. The e-notifications that go out better and better, and the positives and negatives are going out by that e-notification, either by text message or email. But there are some issues with some of the services, such as AT&T. People that have that service sometimes may not get their text message, or if they put their email in or phone number in wrong into the pre-registration process, can also play a key factor in that as well.
Thank you, Nicole. Appreciate that. Did that answer your question, Chairman Poole?
As best it could.
All right, I'll be quick then. Moving on to the school response, we do have another group of staff. We have about 17 staff, permanent health department staff, and then we've also brought in a team of temporaries on as well that are helping with that school response. So the role that we're providing for that is that really our team is working with local public health and the schools to identify close contacts. So we know that there's a positive case, and then again, our team's either working with through local public health or with the school directly to identify who the close contacts would be in that school, and then providing technical assistance and guidance to the schools on mitigation strategies that they can do within their schools and classrooms, and then making sure that parents are getting notified and letters are getting sent out so that families can be alerted to that they're a close contact and that they would maybe need to be quarantining. So that team, as you can imagine, as with all the teams, do have some challenges. We do have some schools that we've got, just since the orders were put into place, we've heard that there are some schools that are not going to be following the orders. They're not going to be following the mask mandate. And, our job is to provide that education and technical assistance and let people know why it's so important. It does get discouraging sometimes to hear stories about schools going against recommendations, but we're really here to support them and continually let them know we're here if they have any questions. And then again, I guess we already talked about the results notification. That team is really here to support Nicole and what her team does, and to support the lab functions. And so I just need to give a huge shout out to all of the health department. I mean, truly the hotline could not do our job without Nicole and her team and them giving us information. Kirby, we have a disease control liaison. We have calls with the hotline team 3 times a week just because there's so much information that's always coming out. And those hotline operators have got to stay up to date with everything. And so we're in constant communication with those hotline operators. But if it wasn't for, the people that I just mentioned, and honestly, Dirk, Brenda, and the lab, and everybody feeding information and making sure that the hotline has that information, we would not be able to give the accurate and timely response to the public. So definitely a team effort, and we're very grateful for not only our internal partners, but our external partners, because if you call the hotline, there's a menu of services, and that press 2 function is the caseworkers. But we also have our internal food and lodging. That's one of those. If there's a restaurant or something like that calling, we also have the North Dakota Safety Council, who has been a tremendous partner with us. They're one of our options that people can press if people are having questions about how to be cleaning or disinfecting. And then OSHA is another important partner with us. Also been working very closely with Commerce on questions. So I'll leave it with that if anybody has any questions for me.
Council members, questions? Well, I guess I have a follow-up question then. And you were speaking about non-compliant schools, and this might be a Dirk question, I'm not sure. Are we working with the Department of Public Instruction in some way to incentivize schools to actually follow best practices?
Dirk,
you go ahead.
DPI has been a integral partner with us in terms of the K-12 response. They're one of the team members that Kim's talking about of the task force that we have with our K-12 response team. In terms of incentivizing, I don't know that we're providing any additional incentives other than the only incentive that we really provided in terms of mask wearing was our change in terms of close contacts, where if an individual was masked and in close contact was masked, they were allowed to continue going to school while self-monitoring for symptoms. And that has been really, really effective from our point of view. I would say there's just a general concern I have as a state health officer, as my role normally as chief of staff, is if schools aren't willing to follow what is essentially now state law at this point, I just have a general concern about that school the liability they may be causing, the risks they may be putting onto that school system. And so we just want to keep educating them on the value of masks. We want to keep educating them on why we have masks in place. And we also want to make sure that they understand that the ramifications that can happen when individuals aren't masked. So those are kind of the avenues that I would say that we're communicating.
Yeah. Dirk, thank you so much for that. That's always the risk you run when you're thanking people, you leave somebody out. DPI has been a huge partner to us. I will let you know that there's a healthy return to learning team. And so we have Dr. Guy Tangadal, Dr. Fran Rodenberg, and Keith Johnson, who we've brought in. We brought them in August as experts that are helping with that, in addition to all the other people that are working on school response. There is town hall meetings that are held every Tuesday at noon that all the school administrators hop onto, and there's different topics that are covered every week. I will let you know that yesterday during the town hall meeting, Superintendent Baszler, this question came up. And so one of the things that Superintendent Baszler said yesterday to the more than 200 administrators that were on the call and other school staff is that schools do have a responsibility in order to get their funding that they follow federal and state laws and rules. And she, of course, put it much more better than I can, but she was pretty direct and let them know that there was an expectation that in order to that every year schools have to submit their plans and stuff for approval. They're approved to be able to be a school and operate. And so she reminded schools of that pretty firmly yesterday. So I just wanted to let you know that.
And so those non-compliant schools are communicated to her and her staff. And the reason why I asked that is already from Monday to yesterday, I'd already received notifications twice by people concerned about what they were seeing in schools. I'm sitting here going, oh my goodness, this is coming up in a hurry.
Yeah.
So if I could expand on the question and then hopefully get additional feedback from Dirk. This goes beyond the schools, but there's also law enforcement that is refusing to enforce the mandate. What are the options that are available since this is in place now? How can there be teeth behind that mandate?
Yeah, thank you for that question. That is a really good question, and it goes to the heart of why maybe a mask mandate might have been, or a masking order, I should say, was delayed. Is in the end, it is a local decision and local function in terms of enforcement. That's always been the case. That's always will be the case. It's an infraction, so I mean, it holds at the same level as a speeding ticket, right? And every time somebody speeds, they may not be cited. They may be provided education first, and or if they're doing something egregious, they may be cited at that time. That was sort of the avenue that we were hoping people would utilize, as they would provide the education, they'd provide the support, they'd provide the reasoning. In egregious cases, they would cite. I know that Bismarck Police Department said that that's the avenue that they're going to take is along those lines. It'd be followed like any other law, but ultimately, if a law enforcement does not want to cite and does not want to follow through with that, we have limited tools to require them to do so. It's within their discretion and their choice. The other avenue we could do is look at state's attorneys, but once again, they have to work with law enforcement to make that more viable option. We gave them an avenue. They just have to walk the path.
Yeah. Thanks, Dirk. I appreciate that. And the idea that they've taken an oath to enforce the laws of the country and the state, I think needs to be taken to heart by them a little more strongly in some cases, maybe. Is there anything that we as the council can do for you as the state health officer to provide a continuum of infraction level enforcement or anything like that maybe we don't need to do it right now, but we need to think about or consider at some point providing that sort of support and scalability that you might need?
I heard Dr. McDonough's comments and the idea that they'd have tiered levels. That is already something they could do if they wanted to. That's already kind of an option on the table. And infractions always up to 1,000. It's not like you jump right to 1,000. There is some flexibility and discretion on how they want to utilize that tool. So I don't have a concern. I think the idea of having it in an infraction and having it be where a local jurisdiction or a law enforcement has that flexibility was one of the selling points to the masking order to begin with. And I think if you start to, and I'm not sure if this is in your authority or not, to be frank, but if it is, and you do this, and you start tiering what the penalties would be, I think there'd be a lot more pushback than we're seeing currently to the masking order. Because to be honest with you, the feedback that I've had, to me, there has been plenty of feedback that says they're against the masking order, but in general, it's been more positive than negative on that. It's really the activities that have been suspended that seems to be the pressure point for the community.
I appreciate that. And so there's already the mechanism in there for scalability and discretion in the way the order is implemented.
Yes.
That real premise. Okay.
Chairman Poole, there was just one more thing. We do have a team of people that are also checking emails that are coming in. Just wanted to alert you that we've already gotten a couple emails this morning that are addressed to the State Health Council. So we will be, can you just, if we send those to you, Chairman Poole, do you send those out to everybody, or we just don't know how Pamela did that? We're kind of filling in for her.
Yeah, those that were requested to go to the committee, she just did a CC to the entire committee.
Okay, we'll make sure that all of you get those emails. Thank you.
Thank you. Further updates, Dirk?
Just the last update will be Nicole Brunel. And so I think we wanted to kind of marry that with her presentation of the section that's been created. So perhaps we could jump that up in the order so we can kill two birds with one stone with your approval.
Let's do that. Nicole, thank you.
Hi, everyone. Thank you so much, Council, for inviting me on to discuss the new Department of Health section, Research and Response. This was an order from our past state health officer, Dr. Andrew Stahl, who had a vision to have a section that could have the ability to primarily focus on what our state's current health crisis was and provide the research, surveillance, outreach, and response immediately. So the North Dakota Research and Response section was created on June 1st with myself and one other person. We are now up to 11 employees with the hopes of being able to find funding to hire on more to assist with that statewide outreach. There are currently 3 divisions in the section: outreach and surveillance, medical training and support, and then health informatics and development. So with our section, we assist in many different levels. We work very, very closely with all of the other sections in the Department of Health. We assist with the testing strategy for the state by providing assessments and recommendations to our leadership. We also do a lot of research, many different types of tests that are currently available. We provide performance projects on them in comparison to the PCR tests, and also do perform research on what other states and countries are doing in their response to COVID. We collaborate with multiple different health stakeholders across the state to ensure that they are receiving the assistance and resources that they need to respond to their COVID-19 response. We work closely with NDIT with the electronic registration process that we utilize called Dynamics. And the use of the e-notifications of those results and making sure that all of the facilities are also receiving their results from not only the state lab, but also MACO lab. A lot of the different entities such as long-term care facilities need those reports in a timely fashion. So we help provide that assistance. Like I said, we collaborate very closely with all of the Department of Health sections. We have to work, and we do work very closely with the lab. I have one of my offices down there to make sure that I'm there if anything occurs with the testing events or collections. So we assure that the testing events are being scheduled appropriately to accommodate the lab's current capacity. We currently are scheduling anywhere between 60 to 70,000 tests a week. So we need to be very, very identify very, very closely and look at that to make sure that we're not going over that. We don't want to break our lab, and we don't want to, but by still providing all of the testing events that are needed. So we do utilize MAKO for those additional tests that are above the lab's capacity. We also do, like I said, perform the testing comparison projects. We're currently working on the Binax in comparison to the PCR tests, and putting that data together to bring forward to show where this test, the Binax test, would be best utilized across the state. So we're working on that and the distribution recommendations for it. In addition to that, we also assist with the lab's testing validations by obtaining specific specimen collections for them to run those validations. We work very closely with Kirby Kruger's crew at Disease Control and Epidemiology to look at the areas across the state and identify either potential or current outbreaks that are happening, trying our best to be as proactive as possible instead of solely reacting to some of the outbreaks that are happening. We'd like to see where different events are taking place, street dances or fairs, large gatherings, where we potentially will need to be testing if we are unable to stop those events from happening or recommend them from sustaining those. We also assist health resources by providing training and guidance for the testing teams that go out with the specimen collections, with the swabbing, blood draws, PPE, the different testing supplies that are being handed out not only from our state lab, but also for MAKO, and then the packaging and delivering of those specimens to the different areas. We also work very closely with Kim Mertz's crew. They do an excellent job with that hotline. We try and provide them as much guidance and answers to the questions that the citizens have, and also their concerns. We have divided the state up into 8 regions where we have identified a local public health lead to oversee those 8 regions. So we're able to break it down and be able to provide the testing that is needed in the different counties. They also assist with the testing of our universities and colleges across the state. They have their team, their local public health team, in addition to, it's usually about a 12-member National Guard team that assists them on the ground. So it's been a really great team that we're able to put together to assist with this COVID response, working together with all of the 28 local public health units, making sure that they have everything they need with not only testing supplies, but also the iPads, electronics, results, so they can get those out to their citizens in their counties. So with the different divisions in research and response, the outreach and surveillance, we have 4 main categories and 4 main coordinators. So we have our at-risk community coordinator, who is that liaison, and primary focus is our corrections, behavioral health, group homes, homeless, our federally qualified health centers, working with them on getting them the testing supplies that they need, getting testing events scheduled as well. And then we have our student health coordinator who works with higher ed, so NDUS, K through 12, school programs, daycares, and providing that outreach to them when they're needing that assistance. We also have our local public health, we call it the public health coordinator, that works closely with Sherry Adams, who's kind of our executive consultant, with the 8 regional leads, works with them closely to develop strategy for the testing events across the state. She also works with our tribal communities and our critical access hospitals. And then our last one is the long-term care coordinator, who has 2 different schedulers under her and assists with being the liaison between Long-Term Care Association, the Department of Human Services, VP3 group, disease control, and making sure that the CMS guidelines are being followed. And so we're assisting those long-term care facilities in the scheduling of their events so they stay in compliance with that. The other division was the medical training and support. So we work closely with Tim Weidrich's section, Health Resources and Response, in providing that education to the multiple DOH employees that are out there on the ground and assisting with the response, from specimen collection to working in the long-term care facilities and critical access hospitals, providing policy and procedures for them to utilize across the state. And then our last one is the health informatics developments, where we have Shar Stroh, who's come on, and she's basically the liaison between all of the different IT systems that are being utilized in our state for this response. So the lab has their facility portal, lab facility portal. They have StarLIMS that they utilize for getting those test results out. We have Dynamics, which is utilized for the registration, the contact tracing, and also the resulting for our citizens, whether it's local public health, public events, or the long-term care facilities that are utilizing the Dynamics right now. And then also is working with the Mako facility and their software system into that. So being that kind of liaison between them all. So it's really great to have her on, because she can assist with the resulting, and when things are not coming in that 48 to 72 hours, it's really nice to have that person that has the ability to have knowledge of all those software systems and bring that together. So other than that, that's all I have.
Okay. This is Dwayne again. I'm going to follow up on something that you'd said, and that is that your unit, and I'm really glad Dr. Stahl sort of brought you into the fold here and developed this program, because I think the analyses of the data and looking forward with what we might be able to do is just as important as retroactively looking at who has it and who needs to be notified. The idea that you're identifying areas of outbreak, possibly demographies of outbreak, how does that fit into an existing strategy or proactive response from what you find? Because I'm going to say, at this point, maybe I'm informed, but I'm not sure I've seen where informed decision-making is actually implemented.
And so with that, it's really great with the local public health regions that we've developed, because they know their citizens, they know their areas, they know what's going to be happening. So when they know that there's going to be a street dance, we cannot stop it, but we can work together to recommend to that city council, possibly postponing it or canceling it due to the fact that having that large gathering could be the result of a huge outbreak. So our section can only provide that assessment and recommendation. It would go up to leadership or to those individual counties and areas to actually make that decision. We want to be proactive. We want to have some mitigation in areas, but with what our current or our past mitigation process was, we were being more reactive to things more than what we could be proactive.
So when you're looking forward, you're more than anything providing communications and advice and scaling risk for the local decision makers, not necessarily do you have a conduit to actually having action.
Yes, that's correct.
Thank you. Other questions for Nicole or the standing up of the research and response section? Thank you, Nicole. I think you're going to be a valuable asset to the health of the people of North Dakota. I appreciate everything you're doing and all of the units of the health department, especially those that are interacting with you and that you're supplying information for.
Thank you, Chairman.
Dirk, are there any further?
Nope, that was the COVID update that we intended to bring forward for the Health Council this morning.
Okay, thank you. Discussion by the council with regard to the update? General discussion?
I guess from my standpoint, listening to all of the presentations, you don't really realize from, the outside perspective, all of the moving parts and everything that is going on in regards to that, and not stating that they're not doing a good job of informing everyone of that. But to just understand the magnitude of what is all going into this, I don't know, in a general sense, that could be shared with the public to help them understand how everybody is affected and what it all takes to try to get this under control. I don't know. I feel that there could be some areas of strength, and I'm not sure if this is the area we talk about it, but as far as a more of a PR and education piece of being able to help our public understand what it really does take for all of us to be together in moving forward with trying to get this under control. It's amazing to hear all of these updates, to just really know how many moving parts it is taking to try to get this under control. I just think that's something that should maybe be shared in some way.
I hope the public is listening in, and those who communicate with the public are listening in and understand that these are not just political decisions made on an administrative level to take control of anything out of their lives, that these are really based upon absolute career professionals who only have the health of the citizens of North Dakota in mind, are trying to provide the best advice they can, best guidance they can, based upon data-driven information. And that this is based upon science. And those who are best equipped with the scientific tools are providing the advice to the people that make decisions. And we should be thankful that we have that capacity and the competency that Dirk and his predecessors have assembled in this staff to provide that competency.
You said it so much more eloquently than I did, Dwayne, but that's kind of what I was looking for, is it isn't a political based decisions on how these things are being handled, that there's so much more to the entire equation than I think a lot of people understand.
Chairman Poole, if I could make a comment as well. Jenny's comments really triggered another thought in my mind, that maybe we don't communicate as effectively from a healthcare provider perspective. And certainly Dr. Brousseau and others can provide some additional input, but the healthcare system itself, whether it's the clinics themselves that are trying to help provide care to those that are positive or have concerns about that they're positive, those providers and those staff members are taxed to the max. And certainly whether it's a critical access hospital or a tertiary hospital, all of those facilities operate on razor thin staffing levels already. And then when you end up having close contacts or positives that have been acquired within the community, it provides additional stress on healthcare organizations. And maybe sometimes we take for granted just how taxed those healthcare facilities are with already meeting the challenges of financial status, et cetera. But then when we add in positives or close contacts, that makes the challenge even more difficult. And we also recognize the assisted living facilities, basic care facilities, and long-term care facilities that are also on razor-thin staffing levels. And when we then have, again, positives or close contacts from community contact, et cetera, it puts additional stress on those healthcare providers, let alone the challenges that the residents in those facilities have, because they can't have visitation because of federal regulations. And it does create, additional depression, anxiety, et cetera, regarding that. I just think we just need to make sure that we recognize those challenges that are out in the system, and anything we can do to mitigate or reduce those levels of exposure helps the healthcare system immensely. Thanks, Jenny, for bringing that up, because that reminded me of those comments that should be shared as well.
Those are very important comments. I appreciate them. The connectivity of that web and the risk that in reducing risk to the overall population, you're not only reducing risk to those who would need services by the medical community, you're reducing risk by reducing the infection level that happens to those workers as well, so they're available to treat. I think that's very important that people understand that it's about the entire web of infectiousness, that it not only affects individuals, it affects everybody treating them. And it affects our economy too. I mean, people not being able to work affects our economy in a large way. I will tell you this. I'm an economist as well as a biometrician, and I played with the numbers, and just looking at the mortality data for North Dakota from this pandemic, and only those attributed to COVID deaths up through yesterday's report, the value of a statistical life application to those by age category actually says that, and human lives are more than just the economics of a human life. They're much more than that. But I know that a lot of people make decisions based upon monetary sort of valuations of things, especially when they're looking at trade-offs in economies. The loss of life in this state, it would be valued at over $6 billion at this point in just the value of the statistical lives. That does not include any other economic contributions to the state that might have been made. That doesn't include hospitalization costs, treatment and release costs that would also be added to that if you were an economist looking at the cost of this particular pandemic. When you start looking at those numbers where you're looking at $6.3 billion to this point in just the loss of human life, you start to realize this is a lot bigger than people really think it is, just because 1 in 1,000 people have passed based on those numbers in our state already. That's really disconcerting. 1 in 76 are active positives. Those are very disconcerting numbers, and I'm really glad and really supportive of the mechanisms that have started to be put into place to start to address the connectivity and simulating immunity by wearing masks. And I think the important thing that I want to get across to everybody that's a consumer out there is the idea that it's really accountability on us. And what I'd like to see put in place, and I'm not sure whether you can facilitate this, Dirk, is some sort of a benchmark or action mechanism where it becomes clear to the populace that wearing masks is their accountability, that if they do the right things to break the spread of this virus, that there are benefits of when and at what point various mitigation measures get taken back off the table. However, if we do not participate at some level and it continues to spread higher, that there are specific benchmarks or points that are data-driven where additional actions might be needed. I think by knowing where our accountabilities are, it becomes basically the ownership of us as individuals to help break that, either by socially distancing, by wearing masks, by basically following the guidelines that have been shown to mitigate the spread of this disease.
Well, and to piggyback on that too, Dwayne, when we talk about the North Dakota SMART, we all know there's a lot of Germans, Russians, and Norwegians in this state that can also be North Dakota stubborn. So, is there a way that, we've tried to allow the North Dakota SMART, and we see our numbers escalating, and we see, is there a way that we can promote okay, we've tried that, it's not quite working the way we were hoping. Can we all band together and try masks, not the mandates? I think what happens is when we use words like mandate, it's an immediate pushback to people saying, that's my right. I don't want somebody to tell me what to do. Is there a more positive spin on, what, can we try this for a month? But you know what, we need everybody to be part of this to see if it works and then see what happens. If we only have 40% of the people doing the masks and feeling like they want to be part of it, and 60% are not, we're not going to be able to see the magnitude of if mask wearing is appropriate. So I don't know if there's a different way of messaging that. And I know we've had masks up North Dakota, which I think is great. But even when we've had discussions, I've heard the word mandate a number of times. And I'm just wondering if there's a different spin we can put on it, as not as much as, we're taking your right away. It's, trying to do a more of we're all in this together type of message. Not sure.
Yeah, I would say that's the attempt we're trying now. It may not seem that way, but that's sort of the attempt we're trying now. Is we have had pretty consistent message that says individual responsibility, we can all make an impact, we can all save lives, and that's all very true. But that hasn't changed the slope of our numbers. That hasn't changed the slope of our hospitalizations. It hasn't changed the slope of our deaths. And so this is sort of that next step of, let's do this for a month. For a month, can we commit to masks? For a month, can we commit to having restaurants closed at 10 o'clock? For a month, can we commit to doing all the things that we've been saying we needed to do? Can we do it for a month? We know holidays are coming up, and those are going to be significant areas where spread can occur. So can we just do this for a month and see where we're at? Can we delay sports for a month? And so the kids can get back to playing, can get back on the field, so we can ensure that kids go to school. This is their message. It's just a question of whether people want to hear it.
That's a really good point, Dirk. We hear what we want to hear, right?
And I think it's important that we implore the general public, whether you're a business, whether you're the health department, the health council, or healthcare provider, our message to the community should be help us help you, because that's what we're trying to do for sure, whether it's any of those groups. And we certainly hope that individuals engage.
Yeah, I would point out that masks or any other mandates are not anything this council, the governor's office, the legislature, local governments, public health units, anybody really wants to do. What it does is it basically is a statement about we've not been accountable to ourselves as a public in knowing what the right things to do are and not necessarily implementing them at a very reasonable cost to ourselves, and a huge benefit to those who are paying the ultimate price right now. I think that goes a little bit to part of what Dr. McDonough had said in looking at the mask wearing percentages and developing specific metrics. Then the question becomes the big thinking by Dirk and his group that provide advice to the governor on, well, how would you set those metrics and what would those metrics be at for specific actions? I guess the point there is that this is all on us as citizens to do the right thing. We know what it is. So, any other discussion with regard to the COVID updates? Okay, then let's move on to the next item on the agenda, which is the primary care office. Bobby Will, I see she is online.
Good morning, Chairman Poole and council members. I'd like to start with where we left off last time, and we actually did discuss our last two meetings on the definition of physician. So after our last meeting, I ended up sending an email of the very original. It was House Bill 1555. That was one question that came up. That bill was in 1991, so 29 years ago, when the physician loan repayment started. And at that time, they did say allopathic and osteopathic medicine. We discussed a variety of things because of the podiatrist who applied this time. So I just wanted to know if you guys have had any more thought. Do we need any more clarification, or where we want to go with that? So I'll bring it back to you.
I believe Dr. Brousseau was leading up our investigation into that. Dr. Brousseau?
I've talked to Bobby about this on the phone, and we've had a few email exchanges too. I think with the podiatrists, it's kind of a stretch to include them in this loan forgiveness program. And right now, I'm not sure maybe we could at least table their request for the time being, since we have a lot more important things to deal with, and since our available funds are running out too. That's kind of where I think Bobby and I have agreed on that. Kind of where we stand on that then.
So sticking with it as described in the legal history.
The way it has evolved has been fine, and we should just leave it at that for the time being. And those who are eligible now, right with that group.
So, Bobby, do we need a motion on any sort of an action, or we just let it table and stick with the definitions as they already exist?
Yeah, we don't need to vote. We'll leave it as it is in the definition in the century code.
Thank you.
And with me too, I'd support that plan.
Okay.
Any other questions or comments on this from the rest of the council? Next, Bobby.
Okay, next, I do administer that federal state loan repayment SLRP program, which the last few years we've had that 540,000. I did send that to you just with our grant ending August 2020. It was actually the first time we didn't use it all, and I do attribute that to COVID. My contractor who does the promotion, we didn't have obviously the same promotional activities going to the schools. We weren't getting into the clinics like usual. The clinics were busy. So we did have 208,964 that were not used out of the 540. Our last two meetings ago, you guys were a little concerned maybe we wouldn't use it all. And I said, well, we usually do in the summer, which is historically been the case, but this summer was different. So I just wanted you to have that information, and you have the list of where all of those 16 providers are located. But along with that, I wanted to update on the numbers of loan repayment. So you know, the update that we get from the national level is in September of each year. And so as of September 30th, the National Health Service Corps did award 48 North Dakota providers loan repayment. So that's 100% federal dollars. And then also as of September 30th, we had 49 in this SLRP program. So that's a total of 97 providers that have federal funding. Of course, our SLRP providers, it is that one-to-one match with our communities. So 97 providers there. And then with our state program, we have 98 providers under loan repayment. So that's just under 200 providers in North Dakota as of September that are in a federal, state, or a state loan repayment. So does anyone have any questions there?
Bobby, what is that in comparison to other years? Is that increased as far as federal funding for providers, or as far as a comparison in numbers, you know?
It actually has been increasing over the last few years, but I do not have the exact numbers, but I will get those for you.
And then the amount that's remaining, the balance that's remaining of that 208,000, is that something that can be carried forward for future loan repayments, or is that no longer available since it wasn't used by the August deadline?
I could have applied to use it, but again, with us in the middle of COVID, I did receive another 540,000 in September. And with all the uncertainty, and again, we're still not in the schools or in our facilities promoting, so I did not ask for the extra.
That just turned back again. Okay.
Yep.
Bobby, are these providers primarily physicians and nurses, or what are they?
They're a wide variety. Last time when we met, I did give a sheet of the breakdown, but I will send that to each of you again so you have that.
Thank you.
Mm-hmm.
Yeah, Dennis, it's everything from pharmacists to nurse practitioners to sort of licensed social workers to medical practitioners. Yeah, it's across the board.
Any other questions?
Excuse me.
Yeah.
I realize it's across the board, but I just wanted predominantly one segment or system of providers, or is it equally distributed?
Yeah, I will definitely send that information, because I don't have it in front of me right here, so I don't want to assume.
Thank you.
Mm-hmm. Any other questions on that topic? Then I would like to have some discussion moving into the legislative session on what you would think of two proposals for policy with changing one, adding a discipline, which we did have a little bit of discussion about that almost 2 years ago, and then some language change. So the first thing I just wanted to talk about was, in our behavioral health area, we do have 5 disciplines right now. And for the last 2 years, I have had a number of stakeholders that work with the autistic task force talk to me about adding the behavioral health analysts to our discipline. And just a little bit of history, a behavioral health analyst does need to see a child that's in Medicaid, before they can have services. So they have to be evaluated, but they cannot take more than 15 clients. And we have roughly 1,500 children that fall in this category. So that would mean we need 100 behavioral analysts in our state. We have roughly 40 behavioral health analysts. So this would be an opportunity to really try to attract behavioral health analysts with that shortage. I do know the difficulty again with loan repayment new awards being in the optional request. And we're definitely not asking for any more money. So that would have to be divided up with the 6 slots I have, with already the 5 disciplines that are in behavioral health. But I just wanted to, this group has given us some excellent data at the health department, and it's just something we wanted to talk if it would be anything you supported.
So what's the reasoning for the limitation to 15?
You know, I'm sorry, I don't have that information. That's workload. They don't want them to have more of a workload is what they have in my information. So I can get more details on that. They just said that that's not what they recommend. Their caseload is 15. So I don't know, Kristen, if you have any information on that at all. Okay.
No, I don't know anything more either. But I know that this is an area where it's really tough to get people to come into the job, and there's a huge need for it.
Jim here. I wonder if this is something we should take up at our next meeting. Maybe we could have devote a little bit more time to it, but I wouldn't be feeling up to making any recommendation on that, but I'd be happy to work with Bobby on this again in the future, or maybe we could just make it an item for our next agenda.
When is our next meeting?
Meantime, maybe we could get some more information. You could get some more information out to us on what this is all about.
When is our next meeting?
We're normally scheduled quarterly, but
it looks like it's February 21st, Kristen, and which is
that may be past the be past the date that you can introduce the legislation.
Mm-hmm.
So besides knowing why 15, what other information would you like?
I'm not sure I know enough to know what information I'd like at this point, if that makes sense.
I'm thinking general information on what you're proposing here would be very helpful for all of us. And as Dwayne was saying, maybe we need to have another meeting before the legislative session. Maybe we need to have one in December, and we could even take this up at that time.
You know, one item that might be good to know, Bobby, is what type of certification or degree do you need to be a behavioral health analyst? What kind of, loan payment commitments and those types of things are required with having this type of degree?
They need to have a behavioral analyst certification board certification, but for the proposal,
some of our physicians,
what was that?
The reason I ask is, some of our physicians or some of our applicants have six-figure loan repayments. Some we have caps at 20,000 is the max or 10,000 is the max. It might be important or at least helpful for us to know, what kind of financial commitment is it to be a behavioral health analyst, and then maybe also help us determine if we move forward with this, at what level would we provide support maybe to this discipline?
Well, it would actually be number 6 under behavioral health, which is the 20,000. So right now we have 5
in that group.
Mm-hmm. Yeah, we would just be, that's the only policy change, is just adding an applied behavioral analyst to that list. So it would go under behavioral health.
I think as a part of that, actually listing out all 5 of them and what makes them qualified or unique for those special designations, and number 6, so we can look at them in context, would be useful.
Okay.
And certainly, as recommended earlier, it probably would be good if we had another meeting. Not that we all like to have meetings, but there might be other things that we want to discuss prior to the session and or related to COVID.
I agree. There's some issues that are coming up the state legislature, probably for the 4th time, raising the cigarette tax. I think we need to look at that, see how what percentage our citizens smoke compared to, say, Minnesota, which has a cigarette tax that's off the wall. So yes, there are issues that we need to look at. So I think we should have an earlier meeting.
I've also been asked by several of you about having a monthly meeting just for a COVID update, but having it a much more brief update than what we've been getting. I don't want meetings for the sake of meetings, and if they end up being 10 or 15 minutes and we're off, I'm fine with that. But do we need to look at having more regularly scheduled meetings just so we stay informed and have the ability to take action if actions are needed from this group?
This is Jim speaking again. I think we've heard enough here today that we've got a lot of things to consider, including Dr. McDonough's testimony. I've been a little concerned because I haven't really known or felt what kind of an impact we're having as a council with the governor. Do we have his ear, or is he listening to what we're saying, or are we channeling our comments through the state health officer? I think we're all concerned about wearing masks, and now that we have a mask mandate, I think most of us are probably okay with that. I myself have been concerned that we haven't had any real meaningful input from the health strategist, and it sure seems like whatever the health strategist is coming up with has importance for what the health council does. And we should try to at least formulate a letter to the governor, and maybe request a meeting between a few members of the council and the governor, to face-to-face meeting and see if we can come to an understanding of what's from us and what we can do to help them.
Yeah, let's and let Bobby finish the primary care updates, so we get closure on that at this point, and then we're going into Dirk's section of this, and I think that's the appropriate place to discuss those? Bobby, was there anything?
I have one more. Go ahead, Brenda.
Just to the Health Council members and in relation to the policy change that Bobby's referring to, for that area too, we would be looking for legislative sponsorship. So I think your discussion to get more information is very relevant, and that's what we would be needing to have some sponsorship from a legislator to carry it forward. Thank you.
So I do have another policy change that I wanted to talk about, and that is around telehealth. Again, we've in past years, we have talked about telehealth. We do have 50% allowed in our loan repayment. 2 years ago, the federal level went to 100% telehealth. I guess they saw writing on the wall a little bit before we did with COVID. But I did pull the Medicaid telehealth claims data, so I can send that to you, Chairman Poole, if you wanted to see that. But I just want to give you these three numbers. So for January 2020, there were 948 telehealth Medicaid claims. In April, the peak for telehealth was at 13,827. So we went from January of 948 to 13,827. And then it did drop back down. Our September number is 2,122. I believe definitely without a doubt, there's a lot of telehealth discussion, and there are a lot more processes and procedures in place for telehealth. We can certainly think about waiting 2 more years, but I just feel like the direction we're going, we have tried to think about what things over the years when I've looked at loan repayment, what are they doing at the federal level that maybe we do want to adjust at ours. So I'm just proposing again, do we want to consider going to that 100% level? It really would only be impacting our behavioral health, I believe. I haven't seen it in any others, but we have them all in one Century code. But I haven't seen any providers default in our loan repayment except for behavioral health. And I've had no other providers but behavioral health providers call me and we're not able to apply. They've all been behavioral health providers. None have been our primary care physicians or advanced practice providers or dental. So I just wanted to give you that information and see if there's some discussion. And then, yes, I was gonna, and Brenda already touched on that, if there would be any sponsorship. And I know that Senator Roars did sponsor the changes our last time around on loan repayment. And it was also Senator Anderson at that time. So any questions on telehealth?
So you gave some raw numbers. What did those relate to in percentages? Because that's what the metric is here, is 50% versus as a cap versus above that.
So you're saying percentages in their time?
Well, yeah, you're saying 948, 13,827, and 2,122. I was just asking, how does that relate to the percentages of telehealth? Those are raw count numbers, right?
But these are the count number of claims. Yeah, so this is only showing you that our telehealth services, that's the only number I've gotten my hands on right now, is that this is just telling us that our claims, our telehealth services have increased. I actually do have a partnership right now with the Telehealth Great Plains network out of Minneapolis, and we're doing a joint telehealth survey currently. They contacted me to do that when I really wanted to survey our facilities on telehealth. And what they were doing for telehealth through COVID and what they plan on doing in the future. And I will not have those results until December. But we're kind of talking two different things here, because I was talking percentage of time is what Century Code says, 50% of time. So no, the claims are just in number of claims. So they are not related.
Okay, so the cap is percentage of time. And so we really don't know what capacity limits were approached or hit or whatever in April based on a percentage of time. We only know them as claims. So that, to me, it's those two don't really come together as a decision point as to whether or not there's an impediment to delivery of service.
Yep. Okay. Our human service centers are starting to have close to that 75% mark of telehealth. So, and that of course happened during COVID, but again, I don't have the survey completely filled out. I mean, we were in the middle of a phone survey right now.
So what's the downside of opening this up to 100%? I mean, a lot of this is about accessibility for the rural areas to expertise. Is there any downside to telehealth? Does it mean that we'll get more people going to the populated areas and then trying to just serve the areas remotely? Or is the intent here to still get people to those rural areas? In the big picture of what the program's supposed to be accomplishing, how does this affect it?
So I do have also a loan repayment telehealth group, which we're meeting again today at 4. And those are the discussions that we're really talking about with if there's possible policy change. So thank you for asking that. We've discussed, do we even want to open it up for somebody in an urban area to do telehealth into rural, because then we aren't going to attract somebody in the rural areas. But then again, we have had a number of behavioral health clients say they don't want to see somebody in rural North Dakota. They would rather go to the urban area because they don't want to be seen walking into that office in their rural area. So serving behavioral health, which really this telehealth is for, is really challenging. So as far as a downfall, I think we're going to be able, I mean, we can't serve most of our state in the 90% are not being served in behavioral health. So I think this is going to open up more opportunities for rural, but do we want, put a cap on somebody in urban can't serve somebody in rural, or, has to do 50% in rural North Dakota? That's something that I think I'd like to see. So somebody who's sitting in Bismarck or Fargo can't do 100% into rural or into their area. I'm sorry, their urban area. They have to do 50% or 75 or even all 100% into our rural community, because then we would meet our, I guess, our ultimate goal of having our clients served in our rural communities.
So this probably goes into Dirk then. In the context of, it seems like there's some real devil in the details here. Does that make a difference at this point in us supporting this? Or is it one of those things that if we probably have to have another short meeting, and I want to keep it really short in December to address some of these issues, some of the policy issues or Century Code issues that might be promoted. Would that be something that could be codified, or is that policy that we're really dealing with here?
So we would add 2 lines to the existing policy. Again, that's what you guys would, I wanted your support so I could further have those deeper discussions with that task force, especially because unfortunately COVID delayed our meetings. We only had 1 prior to COVID, 1 in the middle, and we're going to meet again this afternoon. So then we'll get a little bit more into those weeds. So if I have your support to further discuss that, then I would propose to the exact 2 language changes, the one for the analyst, or again, you can just axe that off if you don't want to do that, and then the one for the telehealth. They would be a very few words of change into our Century Code. And then I would, yes, have to have a sponsor to take that into session if you decided again, for that when we met again.
Bobby, I would agree that because it is about serving our rural and, underprivileged population, that if we would look at doing a telehealth across the board, I do think there has to be a cap of a minimum of serving our rural areas. That's just a no-brainer that needs to be implemented in that process, whether that's 50% or greater or whatever that number is. I think it should be at least a minimum of 50% serving our rural areas. Because what's nice about behavioral health too is you're not having to take a temperature or listen to your heart. You're actually having conversations. So it's the easiest way to provide services in the behavioral health area. But we need to make sure that we keep our focus on providing those services to rural areas in our state.
Yep.
Councilor, supportive?
Excuse me, this strategic planning that we're talking about, we did this a few years ago when the health department went after accreditation. I'm trying to fathom, what are we looking for in the strategic planning or the strategic planner? It looks to me like double dipping with another salary. We already have a plan.
I think we'll address that when Dirk's section comes up. Right now we're talking about telehealth and behavioral health.
Oh, okay, I'm sorry.
So is the council generally supportive of the direction Bobby wants to take, however needing more detail in what we're addressing?
I agree.
So if a meeting, which hopefully can be set in December, then I will have the further information and then a draft of what that new Century Code would look like with what our task force, that telehealth task force, and then with the autistic task force with their information.
Dirk, would we need to create that as a special meeting, or could we just have another regularly scheduled meeting in December?
Yeah, it would have to be a special meeting because you've already posted all your regularly scheduled meetings throughout the year. And so this would be in deviation of that. And so it'd just be a special meeting. So you're going to want to make sure you have all your topics clearly outlined because that's what a special meeting would be limited to.
Bobby, were there any other?
That's all I have.
Did you have one other policy item, Bobby?
Nope, the two policy items were adding the behavioral health analyst to the behavioral health loan repayment section, and then increasing the telehealth from 50% to 100%, but then again, having a specified percentage of time in our rural communities. So those are it.
Okay. Do you feel like you have enough to go forward and provide what we'll need to make a decision?
Yep.
Thank you. All right, let's move to updates from the interim state health officer and the discussion we were having with Dr. Dufault.
Thank you. So I think we're listening today in this. I'm hearing Jess, I'm sorry.
I hear pans in the background. I'm not sure who's working from the kitchen, but can you please mute?
Thank you. So I appreciate the meeting today. I think we had a really good conversation and good dialogue about all that the Department of Health is doing, our actions, obviously. This past week, some significant actions have happened in terms of mitigation steps that previously didn't happen. So one of them being a state health officer order that I signed in terms of a masking order. It requires all individuals in a business indoors or a public indoor space to be masked, and also in an outdoor space if physical distancing can't be maintained. We did provide some exemptions for things such as religious service, disabilities, or things that would prevent somebody from wearing a mask, such as being incapacitated. So there's various exceptions that are provided. In general, I would say so far the response has been pretty positive, more positive than I expected, to be honest with you. I have gotten thanks. I have gotten not so much thanks. I've kind of spanned the gamut of whether people are for or against, but in general, I think it was something that was very needed. Local public health did submit a letter to the governor expressing their thanks and appreciation for the mitigation steps that were taking place on Friday. As we discussed, this is really a step to say, can we do this for a month? Can we do something? Can we put these mitigations into place? Can we bend this curve that's having exponential growth, especially in a period of time when we know that there's going to be more people indoors, which means increased risk. When we know that there's going to be gatherings of family members who may not have been gathering previously, and it creates even more potential for exposure across state lines and across families. And so this is really, can we do this for a month, guys? Can we do this as citizens of North Dakota to help not just lower the cases, but really the things that have me concerned and have had me concerned are the hospitalizations and the deaths. Cases are one thing that can be triggered by our aggressive testing strategy, but hospitalizations and deaths, that doesn't change based on testing. That's our reality, and so we need to face that reality. We did another state health officer order previous to that order to help hospitals with their capacity of workforce. We changed the positive notification or positive individuals who are healthcare workers. There's an exemption for them now to work in a COVID unit only. And then they can only treat COVID patients. Just for some background on this is something that is allowable under the CDC when staffing gets to a point where it's so stretched that this is sort of the option that's available. I would say that healthcare providers and long-term care facilities have been asking for this change for months. They asked for it when Dr. Mariani was here. They asked for it the first time I was the interim state health officer. And we have been really resistant to doing this change because this was always kind of viewed as a not a great option, but a last resort option. But we got to a point where we were hearing from our physicians, when we're hearing from our facilities, when we're getting requests, not just from providers, but also our disease control team, that we need to make this change. Otherwise, there may be patients that aren't able to be treated by a healthcare provider. There may be facilities that need to shut down. And so when we're getting at that point of a stretch, that's sort of the impetus for my decision to sign that order. It's not something that I wanted to do, but it's something that I felt that I needed to do. So if there's any questions on that, I'm willing to answer.
Yeah, I have a question for you on that. Is there protection for the employee who says, I'm just not comfortable being COVID positive going in and having to work? So I don't want punitive action towards an employee not responding to a call to come into work when they're COVID positive, if that makes sense.
Right. And that, unfortunately, I'd have to defer to the Labor Department on that. I haven't done any deep dive analysis on what that would look like.
I guess mine isn't necessarily a question, but a comment. Obviously being in the nursing world, this has blown up pretty big in the nursing world. And while I understand the last minute, or not the last minute, but the last resort nature of it, I think that sometimes there may have been an opportunity for some outreach prior to the announcement that may have helped this land as a better lead balloon than it did. it came as a surprise to many nurses and felt very demoralizing to people who are on the front line fighting this every day. And so I think that there was some opportunity for maybe a little bit better PR on it in hindsight. Also, I think, we also need to be cognizant of the fact that while that may be a last resort, a COVID positive healthcare worker working with a COVID positive patient does not exclude the fact that they are interacting with a multitude of other people while doing that. And so sometimes it can feel a little bit ideologically inconsistent if we say, you general public came into contact with someone and you now have to quarantine for sometimes up to 20 some days, but you nurse who's been burning the candle at both ends for the past 8 months, sorry, just keep working. So it does sometimes, hit a little hard. And I totally understand the intent of it, but the impact may have landed differently.
I appreciate those comments and completely understand where that's coming from. Like we said, this is not a good option. It's not. It's just the best of bad options from our point of view.
So I think Dr. Brousseau was asking a question earlier that I've had questions on in the past, and that was the role of Dr. Nguyen and him being more engaged with the Health Council if he's involved in setting strategy.
Yeah, and just so we understand, Dr. Nguyen is the Chief Health Strategist for Health for the state of North Dakota, not just the Department of Health, if that makes sense. So it's broader than just what the Department of Health does. It would include DHS, it would include community partners. And I do know that there are several state health council members that participated in his strategic discussions. I believe Ginny did, I believe Kristen did. And I know that we had 2 health department employees, myself and Kelly Nagel, also participated in it. I would say that my involvement in terms of the strategic process has been limited. I know Dr. Stahl initially was involved, but when they got to the point where I took over, it was more on the kind of the same wavelength of where Kristen and Ginny have been involved. So that's sort of where we're at. From my standpoint, I don't have weekly meetings in terms of strategy with Dr. Nguyen other than COVID strategy. So
I guess participating in those, I was only able to do 2 of the 4, but I had actually a little bit better or clearer understanding of what Dr. Nguyen's role is. I was thinking he was more of a boots on the ground, working with DOA, Department of Health, with COVID and all of those types of things, and it really gave me a whole different perspective that's really not his role at all. It's really about putting together a strategic plan for the health as a whole, whether that's exercise, diet, walking paths, whatever the case is. And it really wasn't COVID focused in any way, shape, or form. So just having that clarity of really understanding what his role is as the health strategist for the state was really helpful. And at least for me, from my standpoint, understanding what his role really is. Very different than what I initially thought before I attended those health strategies.
Right. His role as a health strategist is a lot broader than just the health department. I mean, it's state encompassing. So that's more of a governor office driven initiative to be the healthiest state in North Dakota. He does have a role in the COVID response, and he is a trusted advisor to me. But that's sort of different than this health strategist view that I think people are putting that title with.
Dirk, do you feel as he as a resource for you in the health department is outside that scope of his health strategist responsibilities? Do you see that as 2 separate things or as part of his role?
2 separate things. So I would say that they're completely separate, to be honest. I mean, he is the leader of the university task force because of his role within the university system. Obviously, he's a well-regarded and thought of doctor, and he's incredibly intelligent. And it's anytime you talk to him, he gives you really solid and thoughtful advice. So that's why we reach out to him as much as we do. but it'd be similar to Dr. Carson. He's not technically a health department employee, but we reach out to him because he's an expert in the field, like we do with lots of experts in the field.
Jim here, even so, even not everything we deal with is COVID either. So I'm just thinking that there's an overlap here of responsibilities. And I think we as a health council really need to know what the strategy is for the entire state. Just excluding COVID entirely, we still need to know what else is going on. That's why I would like to see Dr. Wynn be maybe a non-voting member of our health council, at least come in periodically and give us reports on what he's planning to do. Otherwise, it kind of comes as a surprise to us sometimes. The other thing, one other thing I wanted to ask Dirk, title now is interim health officer. And to me, when you have an interim before your name, it sounds like they're looking for a permanent health officer, but you're just sort of keeping the seat warm until you get a permanent one. And I don't know if there's a search going on for a full-time permanent state health officer, or if that's going to be you. And if it is you, fine. Go ahead. You're shaking your head. What were you going to say?
It is not going to be me. And that was, to be frank, I don't want to be the permanent state health officer. There's better skill sets and there's better backgrounds for the position. I recognize that, and even taking the role as an interim, it was with the basis that I would have support from physicians, that I have support from disease control experts. I don't make decisions on my own in terms of the decisions that I make. So if people think that I do, that's incorrect. I do believe we have a lot of great experts in the state that can help me navigate these decisions. The authority may be placed on me currently, but I don't make those decisions on my own. I would say that we are actively in the hiring process of a potential long-term permanent state health officer. So the job announcement went out. There has been applications that have been received. I know that they're working through that process. Ultimately, that is an appointment by the governor's office who makes that decision. I have been fortunate enough to be able to provide some input in that process at different times, so I'm thankful for that opportunity. But that's sort of where they're at is, and I think the expectation and the hope is to get somebody in place prior to the end of the year. So that's sort of the goal, but we'll see if we hit it.
Well, I didn't mean to sound critical of you or anything, not at all. But wondering if this was a job that you aspired to. We have had other state health officers, at least one comes to mind anyway, Murray Sagsveen, who was an attorney, and he had 3 medical advisors. Dennis Wolf was one, I was one, Julie Blum was the other one, but he didn't really want our advice very often. And I'm wondering too, you've got apparently three people who are advising you now. Do you get regular advice from them too along the way?
Yeah, and so that is a statutory requirement. And I know that there's actually a lot of states that have lawyers as the state health officer and that have kind of medical advisors. So that it's not as strange as people think. I do have a medical advisory board, which is what you're talking about, which would be Dr. Wynn, Dr. McLean, Dr. Namor, and Dr. Alland. The doctors I probably have more connected with just from a personal level, both because of just working relationships and access that they provided me, has been Dr. Wynn, Dr. Carson, and our field medical doctor, Dr. Connell. And they've been amazing resources. And of course, I reach out to them because they have valuable expertise, and there's areas that I'm well aware that are probably not my strength. And so you reach out to other people that have that strength.
And I'm going to throw somebody on the council under the bus, and I'm going to suggest that Dr. Brousseau would be a good resource for you, and I'm pretty sure he would provide good advice. And maybe this goes back to a conversation we had last time, was figuring out how we communicate better and more frequently from a health council perspective. And maybe it'd be worth having a medical doctor on the health council as a part of that group that you might look to for advice every now and then.
Yeah, I appreciate that feedback, and I do agree. I know that Dr. Brousseau has extended history with the health department. is well regarded, especially with the disease control team. And so it's just an action of me reaching out to another individual to get more input. Then that's something that I'm more than capable of doing, and I probably should be doing. So I appreciate that.
Well, and I certainly support that as well, because that could help narrow the gap of communication between the health council and the health officer as well. So I would certainly support that if Dr. Brousseau would be open to that. But you have advisors that work with you. To what degree are their recommendations taken to heart? Because it seems at times that there's frustration that their recommendations aren't taken to heart or implemented.
Yeah, that's a good question, Daryl. I would say that as has been explained, probably in the press conferences more than any other area, there's multiple factors that come forward when decisions are made. It doesn't mean that I haven't done a recommendation that might be aligned to a position or the guidance that I've gotten from Dr. Wynn or Dr. Carson or Dr. Connell. But then the governor, once we provide our public health background and public health recommendation, he's weighing a lot of other things too. He's weighing the public health recommendation. He's weighing the economy. He's weighing all these different factors in terms of decision making. And his, I guess, the compass that he's always provided us is he wants to protect the most vulnerable. He wants to make sure that the kids stay in school, and he wants to keep the economy open. And those are kind of the three thresholds that we try to operate out of. And sometimes those are in conflict. And do we provide the recommendations we get? Of course we do. Does that mean that they always take hold? No, but they are thoroughly vetted, thoroughly analyzed, and thoroughly discussed before decisions are made. Obviously, this Friday, we reached a tipping point where some mitigation actions, which do have impact on potential economy, although I argue that having healthier people in North Dakota and being able to open up more would create a more robust economy long term than any sort of month mitigation might do. But that's all part of the discussion and the analysis. So yes, long answer to a short question. Yes, I could see at times why they'd be frustrated, especially when they've been so gracious with their time and support to me. But their recommendations and our thoughts are always communicated upward, and I understand that there's a lot of decision points that come into any of these decisions because you're impacting a lot of people's lives and livelihoods, and so I know that there's a balancing act that needs to take place there.
This leads me to one more.
Looks like Daryl froze. So I'm going to basically say thank you. We appreciate you being a steward for the position, and a steward is often harder than being the king. And I recognize that there are a lot of challenges there because there's a lot of second guessing. One of the things that I would like to see, and I don't know about the other members of the council, is I would really, this little color wheel thing that kind of was just changing the colors, but no actual actions behind changes of colors for the most part, doesn't seem to have been terribly functional as a strategy. I'd really like to know from maybe it's only the health department's perspective, but maybe it's you intersecting with the executive branch perspective, what our actual strategy is now in terms of a proactive or preventative strategy rather than just a testing confirmation strategy, and where decision points or benchmarks might be driven by data in what actions come next or what actions get taken off the table. To me, that's the big missing element that not only me as somebody who's been in a lot of management positions think about or look at, but me also as a consumer and citizen look at, saying it almost seems like some decisions are ad hoc or arbitrary. If there was something laid out there that was concrete and actually followed once it's laid out, I would feel more comfortable in knowing how the process is working. And understanding process and accepting process is very important to understanding and accepting the consequences of process.
Yeah, and so I would say that our decisions are data driven. They might be different data points than other people may be looking at certain times. We do have a health analytics team that provides recommendations that come from the analysis. I mean, they did recommend a mask mandate. They did recommend certain mitigation actions, and those have been provided and move forward. And those are done with the idea that there's certain trends that are developing, and we maybe need to nip these trends in the bud. We have dove into areas such as like septic water systems. Those haven't provided as much future-focused information as we had hoped at this point, but it is creating a baseline of understanding that we may be able to utilize that in addition to make decisions in the future. But right now, it's not robust enough. It's not there enough. So much of the stuff we're doing is so novel and new that we're discovering things as we go along, and then we have to shift strategies because there's newer technologies, newer options available. I mean, the example I'd give would be the Binax. Right now, we have a PCR testing model, which is the gold standard and which is super effective. But it also takes time, resources, money, dedication, and at times it can take a week to get a response, depending on the issues or the avenue that we're doing. Or you have a Binax test that's gives you a result in 15 minutes, but it's also only geared to symptomatic people. And then so how do we utilize that in a more robust way? Well, there has to be studies done in terms of how it works with an asymptomatic population. How can we target those people that we don't already have access to? Because right now, the reality is we have community spread. So if you're trying to target a specific community, you throw a dart in a community, they're going to have COVID in that community. That's just where we're at as a state. So what we're really trying to do now is figure out how do we not only identify areas that could be perceived hotspots, but how do we get those people who aren't wanting to test? How do we get those people who are asymptomatic spreaders? Because that's really, to be honest, the danger point of COVID-19 in comparison to other situations is the amount of asymptomatic spread that happens with disease, people not even knowing that they're infectious, is astounding. And if you're feeling fine and you don't know that you're spreading, well, then you're going to be walking to a lot of different avenues and areas where you'll be spreading this virus. And a lot of times you don't want to get tested because the results or the ramifications of getting tested are more negative than they are positive. And so how do we make sure that happens? And those are kind of the analysis that we're trying to do and navigate. And we're also trying to do it in an atmosphere where, you do a mask mandate and you get both threats and thank yous. You do testing and people say, well, they're worried about false positives. They're worried about false negatives. It's an atmosphere where anything we do is politicized. So we're threading a very fine needle, but we're doing it based on data, and we're doing it based on kind of the evolving technologies of the time.
And I would even go a step further. You're doing it based on the best data you have available to you. If you had a wish list, you'd like to know somebody is shedding virus before they're symptomatic, and there's just no way of really getting there.
Everybody has to wear a mask.
That's why.
Can I ask a somewhat unrelated question? Okay, Dirk, and sorry, I had to step away for another COVID-related meeting quick while you started, so you may have talked a little bit about this, but just as I think about how the focus of so much of the world, and I'm sure your world has really had to focus on COVID, are there areas within the health department that have had to shift away from their normal work and that we've now got a backlog? And I guess one of my main areas of concern that I'm hearing questions about is long-term care and allegations of abuse and neglect.
Yeah, so I mean, the honest answer is, has COVID impacted how we've delivered services? Yes, it has. It has changed the focus of certain services. Long-term care would be one of them that has changed to what CMS is requiring and asking us to do. I would say we still do surveys. I would have to dive deeper into abuse and neglect conversation to see how prevalent that is. And I'd want to talk to my team before making any broad announcements, obviously, in terms of that. But it has impacted. I mean, you heard the report of what all the different things and all the different team members that are participating in the COVID response. Kim Mertz's team and providing that hotline. Well, that's because they have to step away from other roles that they may be doing in terms of whether it's tobacco or whether it's newborn screening. And a lot of times, right, wrong, or indifferent, they're doing both. It's just, it's not just a 40-hour work week. At times it's a 50-hour work week.
Yeah.
It's a 60-hour. And
I kind of knew that was the answer, but to serve it up on the platter. But I think if we are going to have a December meeting, I would really appreciate if you could bring back a little bit of information, especially on that abuse and neglect allegation stuff.
Yeah, and we'll bring forward the Bridget Wiedner, who is the expert on that.
Dwayne, if I could ask an additional question, and I don't know if Dirk's the right one or if this gets deferred to, but there are a lot of assumptions that the Health Council could make recommendations to implement things like what Dr. McDonough brought forward. I'm just wondering if the Health Council would come to consensus on any of those provisions, what would the process be? And then how would that be implemented, or can it be implemented? Because I think there's folks who think that we have certain authority, and I'm not sure we have it, but could you clarify that?
Yeah, I would say that there's some language in law that indicates some authority. I don't know it's ever been used, to be frank. Some of the things suggested by Dr. McDonough, I'm trying to think through the bullet list. Some of the stuff I don't know that you need to do a formal order or mandate. I think you could just provide recommendations that, hey, we thought this was pretty good, and it could get done. I'm immediately thinking of the masking survey he was talking about. I have no idea what he was talking about, to be honest with you. And so I reached out to Nicole Pesky, our communications person, to see if she had an idea of what that masking survey was. And she also didn't know. So it's one of those things where sometimes people are assuming these things exist or may exist, or maybe we're just misunderstanding what the request is. And so I think those type of things, it'd be nice just to have a direct communication of, hey, because that would be an open record. I mean, you could just basically make an open records request on any sort of survey that we've been doing, and you could get that survey. That's not confidential information or anything. So those are the kind of things where, and then we talked about the citation being tiered. To me, that might be a bit of an overstep, and it might be a bit of a misstep. I guess from my standpoint is currently we have a process where there's an injunction in place, and the local decision makers who would actually do the enforcement, both the law enforcement and the state's attorneys, those are really the ones who are going to make the judgment and follow up on that action. I think it's better placed in their hands than maybe the State Health Council making those decisions. But so I guess my answer is a non-answer. I know that there's some language in law about doing that. I would say that it could potentially put us in an odd situation where you're in conflict with, we're getting direction from the governor's office. You're all appointed by the governor's office, and then us here in the state health department are kind of sitting in the middle, and we'll see what happens, I guess. So if you want to utilize that authority, I would say that it would be it would have to be for a very, very significant reason and purpose. And I would make sure that it was navigated first through Tara, and then also, I guess I would propose having a conversation with the governor's office previous to any of those recommendations to make sure that you're not creating any policy or recommendations that might be not in alignment, or maybe you could help shape the alignment. But I think that's a conversation that needs to happen between the State Health Council and the governor's office.
Jim here, I agree with that assessment. Dirk, you're right on that. You know, when we're only meeting every 3 months, we really can't provide any immediate pertinent advice to anybody, really, I don't think. And I think when the law was written, it was probably quite a bit different. The advisory with the council was more of an advisory board. Now we're more of a review board, I think. And we have to accept that, I think, as our current. I do think that we need to have some clarification, though, with the governor's office, because as somebody pointed out here, maybe it was you, Dirk, or I guess it was Dwayne, and Daryl, I guess, we've had all these people telling us to assert our responsibility here and governor what to do and tell the state health officer what to do. I don't know that we're really in a position to be doing that. New come up, like having an advisory board for you to consult, and as we've all been saying here, this condition has been so fluid, or this situation has been so fluid and changing day by day. I think all we can do right now is provide some consensus review over what's going on.
Yeah, and I don't think was ever the intent probably for this board to be a micromanaging council. And I don't think we need to get there. I don't think we want to get there. I think you're right, Dr. Brousseau, in that we should have an avenue to communicate with the executive branch as well as our communication with the state health officer who's represented in that executive branch. And my understanding from Tara on 2 occasions now is that our authorities really are limited. They're very specific. They're more conducive to the larger policy questions than specific, quick, reactionary sorts of decisions, and we need to be careful in that. And I think we absolutely have to be sensitive to the state health officer and the other staff that if we provide a directive to them that is going to be rescinded or countered by a directive that the governor's office doesn't agree with, we put them in an untenable situation. And quite frankly, they probably have to answer to the one who's signing their checks. And that's a reality of it. I do, however, feel that we as a council have a responsibility and a role to provide our advice to those decision makers. And the question then becomes, how do we better those lines of communication, and how do we develop or craft a message as a group to be delivered?
That's what I was just going to comment on, Dwayne. I know that you've had direct contacts with the governor's office and, stating, hey, we're here to help, any assistance we can provide. But we've never really done a formal, and maybe we haven't, I didn't know, but do we as a health council want to go on record per se to say, for instance, the supporting of the governor's mask initiative that happened on Friday, and just stating that as the health council of the state of North Dakota, we strongly support that initiative, and to state that as a health council, we are here as a resource to be able to provide, information or guidance to help shape, as Dirk said, the plan or the actions of how we move forward as a state. Like I said, I know we've had some informal discussions about that, but have we provided a formal statement, if you will, to the governor's office in that regard? And if we haven't, that may be something we should consider. I don't know, thoughts on that?
I think that's a good idea.
The question then becomes what that statement is and how it's crafted. And I could think of one thing, and that is, first and foremost, I'm not sure there's consensus around the entire table or not, but from my particular perspective, I'm supportive of the governor's mask mandate. I'm glad to see him take those actions based upon what we know the trajectories have been to help protect the public, and especially the public that are not capable of protecting themselves in many cases, those that have immune deficiencies and other underlying conditions that are more susceptible to this, and who they and their families are going to pay the highest price for. I think that it's also part of our role to provide additional guidance or support from the policy perspective. But the only way to really accomplish that is through interaction with the governor's office, not just a letter.
No, and I would agree with that, Dwayne. But again, I don't know if I want to say putting it on the record that we are here as an advisory or as to assist, because probably one of my bigger frustrations is we have informally invited them to our meetings to participate, to be able to provide some input or give us some reports back and have kind of a dialogue or interaction. And I mean, for lack of a better statement, I feel it's somewhat fallen on deaf ears. And it is a bit frustrating, because I do feel, you know, when I listen to so many of the staff members of the Department of Health today talking about team and everybody's in it together, and everybody's at the table trying to be able to do what they can to make the best decisions on behalf of our state. I feel that's where we're at as well. And I do think that we are a good resource. I just don't know how to maybe make our statement known that we are here. I kind of feel like we're like the, what is that Christmas where they're like, we are here, and they can't hear us, you know? I want them to know that we are here to be able to help them, and that we are supporting some of the decisions, especially that's recently been made. Yeah, and I agree with you. It's not just a letter, Dwayne, but does that help being able to kind of push that message out as a step in the right direction?
I agree. And it's just another voice in the choir, I think, from that perspective. And I think the direct messaging that gets to the governor's office and the direct messaging to Dirk that then carries that to the governor's office is, in many cases, the same resources that would be providing us with the information that we would take forward, or the opinions based on that information that we take forward. And I mean, Kirby and all of the others are the same medical epidemiology, infectious disease professionals that are providing Dirk with that advice, and hopefully providing directly in the emergency operations centers that advice. But I think from my perspective, what the council provides is a breadth of healthcare industry review on that advice and consumer of healthcare review on that advice as a filter. So obviously, several of us want to make a statement and share it in a letter or a motion or directive from the Health Council on the mask mandate. So I'm going to open it to the floor to identify what messaging do we want to craft and how we craft it.
This is Jim. I'd be willing to volunteer to write a letter, maybe a memorandum. I like to keep my memos short, side of one piece of paper, and maybe that makes them more likely to be read. Maybe I could put down some of the things we've talked about today, and then we could circulate this among board members and see if everybody wants to sign on to it, and at least just send it to the governor and make a statement like I was saying. That's a good suggestion.
I agree. Just letting them know that we're here, we approve of some of the situations, and then maybe just closing with something that says, you know, we are here for you. Feel free to reach out for us if you need assistance with anything. I mean, obviously not in those exact words, but just to let we are paying attention. If he needs something, he needs to reach out, because unlike, I'm sure that none of our leaders want to be inundated all the time, you know, wanting to be micromanaged by anybody or wanting anybody to be picking on certain issues, but just to let him know that we are here if he does need us, and we appreciate what he's done, and especially the mask mandate, I think is perfect.
Sorry, my computer is kind of freezing up, so I'm having a hard time following the conversation. Can someone just really succinctly tell me where we're at right now?
We're talking about sending a memo to the governor as the Health Council supporting his actions of implementing the mask mandate.
Sorry, it's freezing on about every third word. So I hear supporting his, and then is it just the mask mandate that we're talking about?
So far.
I was thinking about adding on there that like to have Dr. Wynn be a member of the State Health Council so that we're kept informed on what he's recommending to the governor. I guess at least that.
Or even if he's not necessarily a member, maybe getting an update from him on a regular basis. Because I don't know if is that a century code change to be adding another member to our council? I'm not sure. But it would be nice to even get an update from him on a regular basis. I think that would be helpful.
Saying before, Jenny, you know, we're kind of standing here wondering if anybody's listening to us and if we're being heard. And I'm really feeling out of the loop, and there's a whole separate system out there with a health strategist that we don't know anything about. We're all concerned of the same things about keeping North Dakota healthy. I'd like to at least see what kind of a response we get to a memo anyway.
Dirk, I believe you had your hand up.
Yeah, I would just also point out that Dr. Wynn's appointment as chief strategist for state of North Dakota is set to expire in January. So I don't know if it's a permanent ongoing position. So just for that awareness.
In December, he can give us his swan song.
Right. So is there a motion to have a member of the council craft a letter to circulate to the members? But the timing of that is kind of what worries me, Jim, is that we say we're going to send a letter and then ask to circulate to members. And before you know it, it's February and we're sending out a thank you for something that expired potentially in December.
That is true.
So I think maybe the appropriate thing to do here is to just have see if there's consensus to express the support of the Health Council to the governor, and then do a follow-up member iterating that the council showed support.
And maybe it doesn't need to necessarily be like, you know, a paper in the mail type letter, even just an email. I mean, that seems to be the modus operandi. But just to share that we are supportive of what he implemented. I mean, even including, you know, being able to, like you said, I wish it would be longer than 30 days to try some things, but even if it is only for 30 days, to just know that the Health Council is supportive of that. I do think it is important for us to go on record, particularly because we have had a number of people reach out to us stating, you know, where are you at? Where do you stand? I think this at least would be a helpful way to show that, you know, are we supportive? Are we not? Yes, we are supportive of these orders or of this plan that at least the governor has put into place. And maybe it's not just the mask mandate. It's about, you know, being responsible and social distancing and maybe having to reduce. And again, I'm just speaking as one member of the council. We need to make sure that we agree on this as a whole, on what we want to state our support is. But I do feel it is important for us to be able to make a formal stand, if you will, whether it's via email or the like, to just say where we're at as far as our support for this.
I think we have to provide a statement. Just so you guys are aware, Kristen is having real difficulty with the audio.
Maybe Dwayne could just do this. I think you have a pretty good feel for what the discussion is being here today, Dwayne. And if we just send a memo to the governor's office, it would be nice to get a response. So just for the record, I'll say I've tried contacting the governor's office twice myself, and I've never received even an acknowledgement that they got my email. But we would like to have some kind of a response from the governor's office, giving him some positive feedback for the mask mandate. Maybe that's plenty right now. He's more likely to take that advisement than he is any kind of other recommendations we have, I guess.
Okay, and Kristen provided a comment here. She said that she would be supportive of the mask mandate, but she does not support the cancellation of youth sports. So
I think I may have finally figured it out. Tried my third device and my third Wi-Fi connection. So sorry about that.
I just read your text.
Thank you. Yeah, I think I just wanted to make sure that, I was really struggling to follow the conversation to say, are we supporting everything that was announced on Friday evening? Or are we saying we announced the mask mandate? I think just like we talked about a little bit earlier, I think that there was some ideological inconsistencies with the cancellation of sports. And so I want to make sure that whatever I kind of put my name on actually represents my feelings. So I just wanted to make sure that I understood what the conversation was.
I think at this point, we were just talking about mask mandate, right?
Okay.
The one thing we can all be on board with. So if I think that would be a good start anyway. And I'd feel comfortable with having Dwayne as chairman of the Health Council send that. And I don't think you have to circulate it to the rest of us for our approval. That's the way I feel about it anyway.
It would be good to see what you send. I would appreciate a carbon copy or a copy of it on what you send, Dwayne. That would be great.
Yeah, but I don't necessarily need to approve it in advance just to know what was sent.
Yep, agreed.
And I'm more than happy to write something, but I would like somebody to read it before I send it.
Well, if you email it out to all of us, we'll have it.
That sounds like an awful lot like a job for a vice chair, doesn't it?
That's me.
Or the secretary, or, the secretary, whatever.
So, Dr. Brousseau, I'll craft something. I'll send it to you for editorializing, and then
we'll sign all of our names to it.
And then I'll sign it as the chair of the Health Council, representing the Health Council, and copy all of you.
Sounds good.
Do we have any other issues, requests, items we'd like to bring up that we would ask of Dirk?
I have one comment I would like to make, and that is that it took a lot of guts to step in as interim health officer here, and I want to commend Dirk for doing that, because I'm sure it's not the happiest job he's ever had, but I think he's doing a good job, and he's got a good bunch of people working with him, and I'd like to kudos for that.
Thank you.
And I'm comforted, Dirk, also in your expression of the value that you place in those professionals around you, providing you input. I think that's an incredibly important characteristic of a leader. So. All right. Any other old business then? We need to set a time for our interim meeting. I'd like to keep it short, specifically to the point of the behavioral health disciplines and the telehealth. Are there any other items that would have to be added onto that agenda for this council?
Wouldn't we also want some sort of update on what's happening with COVID? We don't know if that's going to be at that point in time or not.
I think that's fine to do that, but I'd like for it to be much more abbreviated than the ones that we're getting, just a little more succinct.
Update from Dirk, maybe.
Sure.
Okay, so there would be 3 items on that agenda: behavioral health disciplines, telehealth, and briefing. I'll call it a briefing from Dirk on the status of coronavirus issues and strategies.
Do we want to just put any other potential legislation as an option just in case something comes up between now and then?
Yes, that'd probably be a good idea. That way we can handle it before the session starts.
Yep.
This is Bobby. I think you said you wanted some tobacco information on that meeting too.
I think our intention would be just to send that tobacco information via email, unless you needed something beyond what was requested in terms of the tax.
Yeah. Do you need a specific action recommendation from us, or was it purely informative? I think it was informative, right?
Yeah, we're already sending. We already reached out to Neil, so it's already happening. So,
yeah. All right.
So do you want possible dates? Is that what you're looking for now, or are we going to do that by email? Or
let's see, Dirk, who's going to be organizing this one since Pamela is going to public service?
that's a great question, Dwayne. I'll have to get back to you, but via email. And yeah, we're still coordinating that and working that out. Londa was gracious enough to step in for today, but she's happily retired as far as I know, and so we're kind of navigating that role as we go along.
All right. How far out do you need, Bobby, in this context? How many weeks out do you need? Are we looking at the first, second, or third week in December?
I'm fine with anything.
All right. So then to the council, is earlier in December better than mid to later December?
the legislature is meeting the first, second, and third, just so you know.
What was that, Chris?
The legislature is meeting for organizational session December 1st, 2nd, and 3rd. So those would be very limited days for me. I also am moving into some patient care roles for the remainder of my time before the legislative session kicks off so my schedule's a little wonky. So I think just find the time that works for the majority of people. And if I can attend, I'll attend.
Okay. And I have a water commission meeting, I believe, on the 10th of December. So is anybody writing this down by chance?
9th and 10th are full of board meetings and budget meetings for me as well. The week of the 16th actually looks a little better. I don't know if we want to pick a Wednesday again. We normally do Wednesdays for our commission or for our council meetings.
Is there anybody have issues on December 16th, which is a Wednesday?
I'm good.
I'm good.
To me too.
Dirk?
I'll make it work.
Especially if it's quick.
Things that we want to get done in the morning and our day.
Sorry, you're cutting in and out for me.
Is it the sort of thing that we want to schedule in the morning and be done with it for the day? All right, so schedule it from 8:30 to 9:30. Limit it to no more than an hour. Tori, Tyler?
Yep, I'm good with that. And mornings are definitely better for me.
I know that you have scheduling.
I'll attend if I'm available that day. As far as my work schedule is kind of up in the air sometimes. So.
All right. Well, let's plan on a special meeting 8:30 December 16th. That coincides well, I think, with the existing health officer order and the timing of where that'll be anyway. So thank you. Is there anything else before the council? Hearing nothing, we'll adjourn the meeting.
Thank you.
All right. Thanks, everyone. Have a good Thanksgiving.
Thank you.